COVID-19 treatment team at Persahabatan Hospital, member of Satgas Waspada and Siaga COVID-19 of Indonesian Medical Association, and member of medical expert of Satgas COVID-19. She had published many research about pulmonary infection, especially in tuberculosis infection and treatment. So, without further ado, please welcome Dr. Erlina.
Thank you, Dr. Jane. I would like to greet everyone. Good afternoon, everyone, the speaker and also the participant. I think we need to proceed to the session right away. First, I would like to invite the president of Indonesian Society of Respirology, Dr. Agus PhD. Please, Dr. Agus, it's your time to give the welcome speech for this.
Thank you very much to Dr. Erlina Burhan. Good afternoon to all the speaker and all of the participants. The webinar from the Indonesian Society of Respirology, Indonesian Society of Mycology, and Department of Pulmonology, Faculty of Medicine, University of Indonesia. I'm very grateful to all of speaker and participants for this webinar. This is a collaborative for doing the seminar about mycosis, lung mycosis especially. We know that lung mycosis is a rare disease, but this disease is difficult to diagnosis and also to treatment. So the knowledge about this is very important to general practitioner, to specialists, especially to pulmonologists. Thank you very much to Dr. Anna to make this webinar, and I'm very happy to give an opening speech for this afternoon. Thank you very much, and wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Our next, the real opening one will be delivered by our Dean, the Dean of Medical Faculty, University of Indonesia. Please, I would like to invite our Dean or the representative staff. Dr. Andon, please deliver your opening speech.
Thank you very much, Dr. Erlina Burhan. Dear ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. The Honorable Dr. Agus Dwi Susanto, as the Chairman of Indonesian Society of Respirology, Dr. Anna Rozaliani, as the Chairwoman of the Activity Center of Pulmonary Mycosis, Professor Dr. David W. Denning is a speaker, Professor of Infectious Disease and Global Health at University of Manchester. Dr. Chris Cosmidis as a speaker, Clinical Senior Lecturer, Division of Infections in Community and Respiratory Medicine at the University of Manchester. Professor Anwar Yusuf as a speaker from FMUI, Professor Dr. Retno Wahyuningsih as speaker from FMUI, Dr. Siti Nadia Tarmizi, Magister Epidemiology as speaker, Dr. Jamal Zaini PhD as speaker, Dr. Budi Antariksa PhD as speaker, and also Dr. Erlina Burhan as a moderator. And also, to my respect to all participants, first and foremost, on behalf of the Dean of Faculty of Medicine, Universitas Indonesia, Professor Ari Fahri, participants that have gathered today in pulmonary mycosis webinar series with the topic of chronic pulmonary aspergillosis addressing hidden threats in high-risk population held by Indonesian Society of Respirology. To our distinguished international guest speaker from the University of Manchester, Professor David Wenning, and due to your willingness to share your valuable knowledge with all of us, visually it will be useful for us to be in our daily practice. Suffering from perpetual fortunately panic burden. Many of these organisms causing such diseases are hardly understood. It's to provide best possible option for our patients. It's grateful for us having this webinar series today. Visually will help us understand deeper into these issues. For this, I wish this will help us. Also, this webinar may help us to think this
for the opening speech. Now let me proceed to the main activities, which is the main session. So we have a very important and well-known speaker for this session, 5 of them very expert in their field, that will share their knowledge and experience and other things that important we need to know. The first I would like to invite Dr. Siti Nadia Tarmizi. Dr. Nadia Tarmizi is our CDC Director of CDC Minister of Health Indonesia. She is also a spokesperson for COVID-19 vaccine. I would like to invite Dr. Nadia Tarmizi to present her topic, what is the strategy and the priority of the infectious disease in Indonesia. Is yours.
Thank you, Ibu Erlina. So, shall I start my presentation? So, I think I'm not the one who expert, but the next speaker will be mostly the expert on this field. And thank you for inviting me in this very important webinar. It's mycology, especially on the mycology topic. So let me share my presentation, but let me talk in Bahasa, Bu Erlina. And thank you for Dr. Firda who already quickly in very short time translate my presentation. Is that my voice is clear, Ibu Erlina?
Yes, it is clear. Yeah. Please, Dr. Nadia, your slide is clearly seen from our screen.
Oke. Baik, mohon izin saya menyampaikan dalam bahasa Indonesia. Jadi topik mungkin pertama ini hanya merupakan pengantar daripada diskusi webinar kita siang hari ini. Terima kasih Dr. Ana selaku Kepala Departemen Parasitologi dan tentunya kepada PDPI yang sudah mengundang kami khususnya Kementerian Kesehatan untuk berbicara mengenai prioritas infectious disease di Indonesia, dan mungkin saya akan lebih fokus saja kepada apa yang menjadi topik pembahasan pada siang hari ini. Ya, baik, lanjut saja. Nah, mungkin mengapa tidak semua penyakit menjadi prioritas di dalam program nasional? Karena ada keterbatasan dalam sumber daya dan juga finansial dalam menangani penyakit-penyakit, terutama untuk bagaimana kita mengembangkan surveillance-nya dari penyakit-penyakit ini. Dan tentunya prioritas setting ini adalah perlu untuk memastikan bahwa dalam perencanaan dan pengalokasian anggaran cukup rasional dan cukup transparan. Dan kita mengetahui bahwa permasalahan kesehatan masyarakat ini selalu berubah dari waktu ke waktu, sehingga diperlukan prioritasi yang tentunya menjadi penting untuk kita melihat berbagai alternatif untuk bisa segera menyelesaikan masalah kesehatan tersebut. Yang penting adalah prioritas ini tidak mudah karena banyak hal yang harus dipertimbangkan, terutama bagaimana kita menempatkan limited resources yang tentunya bisa menghasilkan capaian ataupun memiliki target, baik itu target nasional maupun target global. Jadi di tempat saya di Direktorat Penyakit Menular Langsung ada 3 sebenarnya penyakit yang terkait paru, sehingga penyakit terkait paru ini yang menjadi tadi disampaikan adalah prioritas nasional. Yang pertama adalah tentunya TBC, khususnya pulmonary TBC paru. Kemudian ada ISPA, khususnya fokus pada pneumonia. Dan satu lagi mungkin yang terkait adalah penyakit HIV/AIDS. Sebenarnya kalau kita melihat permasalahan kesehatan paru ini, kalau kita hubungkan dengan 3 penyakit yang menjadi program prioritas di Kementerian Kesehatan, khususnya di Direktorat Penyakit Menular Langsung, maka terkait kesehatan paru ini kita melihat sudah ada sejak dari epidemi HIV. Dan kita tahu bahwa kurang lebih 50% kematian pada ODA itu disebabkan oleh permasalahan ISPA maupun permasalahan paru. Kemudian kita juga melihat adanya kalau di HIV/AIDS kita sudah mengenal adanya obat untuk pencegahan dengan menggunakan cotrimoxazole yang kemudian menurunkan angka kejadian infeksi paru yang sebenarnya ini adalah bersifat sementara. Kemudian dengan kombinasi tentunya antiretroviral ARV, insiden daripada penyakit yang timbul pada paru dan tentunya terkait HIV/AIDS ini juga menurun. Kita melihat bahwa di sini pneumonia bakteri dan TBC ini muncul pada kondisi infeksi HIV di mana CD4-nya masih lebih dari 500 bisa muncul. Di mana kalau kita lihat PCV ini adalah muncul pada kondisi CD4-nya kurang dari 200. Sementara untuk toxoplasmosis, CMV, dan Mycobacterium avium complex ini biasanya muncul pada kondisi CD4-nya kurang dari 100. Dan kalau kita pada keadaan yang lebih kondisinya lebih turun imunitasnya, maka kita bisa melihat bahwa beberapa penyakit dapat muncul dari kondisi tersebut. Kemudian kita melihat bahwa respon daripada terapi umumnya lebih lambat dan lebih sulit karena permasalahan dari efek samping maupun dari status imunologinya. Nah, ini mungkin beberapa yang kita lihat pola khas AIDS pada saluran nafas, mulai dari alveolar, interstisialnya, bronchovascular, tracheobronchial, dan pleura sampai dengan granulomatosa. Jadi ini ada beberapa muncul penyakit-penyakit pada tentunya orang dengan AIDS yang kita ketahui bahwa CD4-nya sudah sangat rendah dan virus viral load-nya juga sangat tinggi. Nah, kalau melihat dari pembagian berdasarkan CD4, maka kalau lebih dari 200, kita melihat ini adalah penyakit-penyakit terkait saluran nafas yang muncul, mulai dari timbul yang ingin saya highlight adalah Mycobacterium tuberculosis, Staphylococcus aureus maupun Staphylococcus pneumoniae. Tapi yang ingin kita lihat bahwa pada CD4 lebih dari 200 pun TBC sudah bisa muncul. Nah, kalau kita melihat pada range CD4 50 sampai 200 pada orang dengan HIV/AIDS adalah kondisi-kondisi di atas ditambah dengan beberapa penyakit lain seperti cryptococcosis, histoplasmosis, dan nordardiosis. Untuk CD4 kurang dari 50, kita melihat bahwa di sini selain tadi penyakit-penyakit yang saluran nafas yang muncul di atas, ditambahkan lagi keadaan seperti aspergillosis dan tentunya Mycobacterium tuberculosis. Nah, untuk infeksi, kalau kita melihat jenis-jenis infeksi yang dapat terkait dengan saluran nafas, khususnya pada ODA, orang dengan AIDS, tentunya kita melihat di sini mulai dari infeksi Mycobacterium yang kita kenal dengan Mycobacterium tuberculosis, MAC yang tadi pada stadium yang sangat rendah CD4-nya, kemudian infeksi protozoa, bakteri, dan jamur. Kita melihat juga di sini aspergillosis juga menjadi salah satu infeksi yang juga sering ditemukan pada penderita dengan AIDS. Nah, kalau kita melihat di sini tadi, kalau kita bicara mengenai aspergillosis atau jamur, ini terutama pada kasus-kasus orang dengan HIV/AIDS dengan CD4 yang sangat rendah. Selain tentunya infeksi cacing yang juga ada. Nah, kami melihat bahwa apa yang menjadi topik pembicaraan pada hari ini mengenai chronic pulmonary aspergillosis sebenarnya merupakan suatu penyakit yang sebenarnya ada pada high risk population. Jadi kalau kita berbicara seperti orang dengan HIV/AIDS dan tentunya orang TBC ini menjadi sangat dekat sekali. Aspergillosis sendiri tadi sudah disampaikan bahwa biasanya muncul atau secara program kami menotifikasi aspergillosis ini sebagai salah satu dari kasus atau penyakit yang muncul pada penderita AIDS dengan CD4-nya kurang dari 100 dan bisa bersamaan dengan CMV, pneumonia CMV, kemudian PCP, bakteri ataupun infeksi jamur lainnya. Dan lebih dari 80% dari kasus ini menunjukkan kondisi neutropenia. 15% daripada kasus ini terdapat riwayat pengobatan steroid dengan atau dengan pengobatan antibiotik dengan spektrum yang luas. Nah, kalau kita bicara mengenai data TBC dan aspergillosis, ini kita belum memiliki informasi yang mencukupi. Jadi saya rasa ini PR juga Bu Erlina, Dr. Agus, dan Prof. Anwar. Kalau kemudian kita mau melihat bagaimana TBC dan aspergillosis ini ke depan. Nah, kalau untuk penderita HIV/AIDS, kita bisa mengidentifikasi bahwa terdapat resiko yang lebih tinggi pada pengguna marijuana. Ini kalau symptoms mungkin nanti akan lebih dibahas oleh tentunya para klinisi. Nah, pada posisi itulah mengapa kemudian program menyediakan obat untuk pengobatan khususnya pada program AIDS terkait infeksi jamur tersebut, yaitu dari cotrimoxazole, fluconazole, micafungin, dan amphotericin B. Nah, ini yang mungkin nanti akan menjadi pembahasan kita selanjutnya dan mungkin kami akan menunggu masukan-masukan lebih lanjut karena sampai saat ini sebenarnya obat untuk aspergillosis ini infeksinya terutama ditujukan pada orang dengan HIV/AIDS. Nah, kalau kita bicara mengenai situasi TBC di Indonesia, kalau tadi tentang HIV juga merupakan beban lumayan untuk negara kita karena estimasi orang dengan HIV/AIDS ini berjumlah 453.000 dan saat ini baru 63% dari estimasi tersebut yang sudah mengetahui status HIV-nya. Sementara kalau kita berbicara mengenai TBC, estimasi kasus kita adalah 845.000, nomor 2 setelah India. Dan kalau kita bicara koinfeksi TBC dan HIV itu ada sekitar 19.000 kasus dengan perkiraan angka kematian TBC ini adalah 96.000 per tahun. Memang agak sedikit menyedihkan kalau kita melihat dari data yang dilaporkan kepada Kementerian Kesehatan, kasus TBC itu selalu kurang dari 90 kasus per tahun. Sementara kalau dari estimasi WHO sendiri selalu dinyatakan kematian akibat TBC ini adalah 96.000 per tahun. Jadi hampir 10 kali lipatnya, 100.000 kali lipatnya. Nah, untuk data ekstra pulmonari TBC sendiri di Indonesia, kita bisa melihat di sini memang sejak pandemi COVID-19, angka penemuan kasus TBC agak menurun. Kalau tahun kemarin dari 845.000 yang menjadi estimasi tuberkulosis di Indonesia, kita baru menemukan 563.000, di mana ekstra parunya 59.000. Sementara kalau kita bicara mengenai tahun 2020 didapatkan TBC ekstra paru 23.000 dan yang di mana 866 ini dinyatakan sebagai TBC tulang. Jadi hanya data ini sebenarnya yang kami miliki, memang agak berbeda dengan apa yang kami miliki di HIV. Untuk aspergillosis ini akan tercatat tentunya di fasilitas pelayanan kesehatan karena mengingat data ini tidak dikumpulkan atau dinaikkan secara kompilasi sampai dengan Kementerian Kesehatan, tetapi data ini ada di dalam fasilitas pelayanan kesehatan. Untuk TBC sebenarnya kita juga mencoba mengkompilasi kasus TBC paru maupun TBC ekstra paru, tetapi data terkait TBC dengan aspergillosis ini tidak kita dapatkan. Nah, mengapa kemudian menjadi highlight kita bahwa Indonesia ini sudah perjalanan panjang untuk kita bisa mencapai eliminasi tuberkulosis. Waktu saya masih staf di tuberkulosis dengan dukungan Prof. Anwar, mulai dari bersama juga Dr. Erlina, mulai dari melahirkan International Standard of Tuberculosis dan juga kemudian berbagai penanganan. Pada waktu itu kita memulai untuk melaksanakan pengobatan MDR-TB di Rumah Sakit Persahabatan. Ini juga merupakan cerita panjang bagaimana Indonesia berusaha untuk menurunkan angka insiden di tuberkulosis di Indonesia ini. Nah, ini yang tentunya menjadi perhatian kami tentunya bahwa kalau kita lihat ranking Indonesia terhadap tuberkulosis ini up and down. Jadi dan bahkan pada saat ini kita berada pada urutan kedua setelah India. Jadi Cina sudah pada angka dengan estimasi absolutnya 833.000, sementara Indonesia masih tengger di angka 845.000. Nah, yang sedikit mungkin menjadi perhatian kita, walaupun kita nomor 3, tapi sebenarnya insiden kita ini paling tinggi. Kalau kita lihat insiden Indonesia itu 312 per 100.000 dibandingkan India dan Cina. Kalau India itu hanya 193.000, tetapi memang menghasilkan angka yang absolut yang cukup besar, 2,6 juta. Di sisi lain, Cina itu angkanya sudah sangat turun, insidennya 58.000. Jadi kalau kita melihat ini sebenarnya yang menjadi kewaspadaan kita, jangan sampai kita tidak segera mengakselerasi karena sebenarnya angka penularan tuberkulosis di Indonesia itu masih sangat tinggi kalau kita bandingkan dengan negara-negara lain. Nah, ini mungkin slide saya yang terakhir. Nah, mungkin menjadi catatan, kita tahu dari berbagai jurnal akhir-akhir ini sudah dinyatakan bahwa TBC paru di mana tentunya 2/3 dari pasien yang sudah kita obati dan kita nyatakan selesai pengobatannya dengan OAT ini menunjukkan atau menyisakan perubahan-perubahan di dalam parunya. Dan bahkan kita juga mendapatkan bahwa pasien TBC yang sudah sembuh dari pengobatan tuberkulosis dan dinyatakan menyelesaikan pengobatan tuberkulosis, ini kemudian memiliki resiko untuk meninggal 2-5 kalinya. Nah, kemudian kita melihat banyak sekali perubahan-perubahan di paru yang walaupun sudah mendapatkan OAT yang kemudian menimbulkan CPA ini. Dan kita melihat pada pasien-pasien TBC dengan kavitas itu biasanya juga ditemukan aspergilloma. Jadi ini tentunya menjadi perhatian kami dari program untuk kemudian bersama-sama tentunya ini bagaimana ke depan kita mensikapi terkait CPA ini. Dan dinyatakan juga bahwa negara-negara high burden country dan tentu Indonesia juga termasuk di dalam 30 negara dengan beban TBC tertinggi, maka proporsi untuk CPA-nya jauh lebih besar. Dan seringkali juga CPA ini misdiagnosis sebagai tuberkulosis. Jadi menurut saya ini suatu pemikiran yang mungkin kami akan mendengarkan lebih banyak masukan dan diskusinya, dan kami juga melihat bahwa diagnostik yang selama ini kita lakukan untuk tuberkulosis dengan menggunakan mikroskopis maupun TCM ini sebenarnya tidak bisa mendeteksi adanya kelainan yang disebabkan oleh non-Mycobacterium tuberculosis. Jadi menurut saya tidak tahu, mungkin nanti ke depan melalui webinar ini mungkin akan menjadi masukan, terutama sebenarnya kalau kami dari program, kita punya 2 prioritas penyakit, TBC dan tentunya HIV, tetapi kita tahu juga CPA-nya menjadi salah satu yang sepertinya akan menjadi permasalahan ke depan. Sehingga kami melihat ini aspergillosis sebenarnya di dalam pengobatan HIV ini sudah berjalan, tetapi tentunya untuk kasus-kasus orang dengan HIV/AIDS. Nah, sementara untuk TBC sendiri, kalau kita ingin bicara mengenai TBC, maka tentunya kami masih menginginkan adanya masukan-masukan terhadap kebijakan untuk kemudian menyikapi hubungan atau bagaimana kita mengintervensi terkait TBC dengan CPA ini. Mungkin dari screeningnya seperti apa, kemudian bagaimana diagnosisnya, karena diagnosis untuk CPA ini relatif lebih sulit, pengobatannya seperti apa, jangan sampai kemudian nanti kami tidak bisa juga memberikan obat atau mendukung pengobatan untuk CPA ini dikarenakan kasusnya ini ada pada kasus tuberkulosis, karena kasus HIV atau orang dengan AIDS itu sebenarnya itu yang dialokasikan untuk pengobatan aspergillosis ini. Kemudian juga kita perlu mengetahui seberapa besar sih sebenarnya masalah TB dengan CPA ini. Kami juga meng-highlight bahwa kalau terkait koinfeksi TB HIV ini sudah merupakan suatu pendekatan yang terintegrasi, tapi kalau kita melihat TB, HIV di tengahnya mungkin ada CPA, nah bagaimana mungkin kita menyikapinya. Mungkin ini juga yang harus didudukan nih antara PDPI dan PAPDI mungkin ya. Itu saja mungkin yang bisa saya sampaikan. Terima kasih banyak. Semoga mungkin memberikan sedikit gambaran terkait program.
Yeah. Thank you, Dr. Nadia. It's a very interesting and eye-opening presentation regarding situation in Indonesia, especially infectious disease. And I'm very happy that you also talk about the fungal disease. I hope you can stay until the end of this symposium so we can have the discussion later on. Okay, dear audience, our next speaker is a very well-known expert from UK. I'm very proud to present Professor David Denning, an infectious disease clinician with special expertise in fungal disease. So we are very, very lucky to have him now. He already published more than 600 international publications and also a book chapter. Currently, Professor Henning chairs the editorial board of the Aspergillus website and also chief executive of the Global Action Fund for Fungal Infection, and yet also member of Sero Task Force on antibiotic AMR, antimicrobial resistance. So to make it short, I would like to invite Professor David Denning to present his presentation with the topic of epidemiology and diagnosis strategy of chronic pulmonary aspergillosis. Professor Denning, the screen is yours.
Thank you very much. Can you just confirm that you can hear me well enough?
Yes, we can hear you very well, Professor Denning.
Okay, thank you very much. So I'm going to talk today about epidemiology and diagnosis of CPA. A lot of the work I'm going to present is from Indonesia, and I'm very grateful to Dr. Findra, Dr. Rosa, Dr. Retno for their important contributions to this work. And yourself, actually, Dr. Beram, you've also been important in this. So that I'm going to cover 4 topics. How common is CPA in Indonesia? Who gets this infection? What are the radiological features of it? And how is it best diagnosed? So the first thing is, our first speaker indicated this, that CPA can mimic TB. So these infections are quite similar. And so the initial diagnosis of TB may be wrong, and it might be CPA. This is true in only a small number of the patients, a small proportion of the patients probably about 5 or 10%, but particularly true in GeneXpert negative or smear negative cases. CPA can also occur as a co-infection with TB and also with NTM infections. So that's the other important differential of TB, is that it's a non-tuberculous mycobacterial infection. And again, you can have that NTM plus CPA. And CPA can also follow TB as a sequela, particularly in those who develop cavitation through their TB course. So there are 3 components when you want to look at the epidemiology of this infection. So here are 2 examples of X-rays from our center in Manchester. You can see a fairly typical case of tuberculosis, unilateral in this case, with soft shadows in the apex of the lung. And you can also see unilateral apical disease in the other patient, which is chronic pulmonary aspergillosis, and you've got pleural thickening, a single cavity, and some thickening underneath that cavity. And without testing, it's difficult to be sure what the right diagnosis actually is. We did some work in Nigeria. Rita Oladele, who's back in Lagos now, and she looked at HIV positive patients and HIV negative patients, and those with GeneXpert or smear positive, mostly GeneXpert positive or negative, GeneXpert positive or negative. And she used an antibody test that's not the best test, but it gives you some indication that you've got 7% of patients HIV smear positive with disease, 10% HIV positive as gene expert negative, 6%. And this group of HIV negative, gene expert negative cases of 19%. And this is the particular group where the frequency of CPA is greatest. In work from Karachi in Pakistan, Dr. Iqbal and others there who've been very interested in chronic pulmonary aspergillosis found that 13% of their patients with active TB also had some form of aspergillosis, most of it chronic, but sometimes invasive disease as well. And like in Indonesia, they also found a lot of patients with diabetes mellitus. So Findra and all of you in Indonesia undertook a very important study looking at the value of testing in the patients to find the cutoff for a positive in patients with chronic pulmonary aspergillosis. And we did something in this study that has not been done before, which was to take the radiological, clinical, and serological data at the end of treatment. So right at the end of their 6 months of therapy, and validate the test and also look at how many patients had CPA. And you can see 26 out of 200 had CPA. These patients had a worse quality of life. Most of them, almost all of them, were culture negative for Aspergillus. And that rate was 13%. Now, in fact, this is a combination of a longitudinal and cross-sectional study. Findra has also completed a pure longitudinal study, and the rate in that study is 8 to 10%. So it's possible that the cross-sectional study picks up slightly more cases because patients are more willing to come back because they don't feel well. And so it may be that the rate is actually 8 to 10%. We had published in 2011 a global prevalence study of how many patients had aspergillosis after tuberculosis. So this is a year or more at the after TB. We estimated nearly 1.2 million people a year, a prevalence, and 375 per year developing chronic pulmonary aspergillosis. And in that, we assumed about a 15% annual mortality. And that data is probably correct, a higher early mortality and a slightly less later mortality, but overall about 15%. And we also conducted a study in northern Uganda in patients who were HIV positive and HIV negative, looking for chronic cavitary, chronic fibrosing aspergillosis, and also simple aspergilloma at baseline and then 2 years later. So how many patients had developed CPA over that 2-year interval, again, after TB. So this is the consequences after TB, not during TB. And we found a 4.9% confirmed disease, 6.3 with confirmed and probable disease. We had 2 patients who had negative antibodies and 2 patients we didn't have CT scans in, but probably the figure is 6%. And it's approximately equal in HIV positive and HIV negative patients. But if you look at how many patients developed CPA over those 2 years, it was 6.5% in those with a cavity at their initial X-ray, and 0.2% in those without a cavity. So a very big difference. So one implication for your country is to do X-rays at the end of treatment and see if there is cavitation, because that is clearly a risk factor for invasive pulmonary aspergillosis. TB is not the only underlying disease in patients with CPA. You can see the rate in different studies was 31 to 80% here, but atypical or NTM infection is relevant. ABPA, so that's fungal asthma. Patients with COPD, and that actually goes up to nearly half of the patients in other studies. Pneumothorax, people who've had a resection for lung cancer, people who've had pneumonia, sarcoidosis, other thoracic surgery, some of that is linked in here, rheumatoid arthritis, other forms of asthma, ankylosing spondylitis, and in our case series, only 1% of patients with no underlying disease, but in other studies, 15% of patients with nothing apparently to underlie this disease. So the question is, how in Indonesia, how many patients do you have with CPA with some of these other conditions? And that's something we don't yet know. So what is the burden of CPA in your country? So we know that TB cavitation at the end of TB therapy is about 1/3 of the patients. The data that Findra and Anna and others have done suggests 8% have CPA at the end of TB therapy. This is only pulmonary TB, so we're ignoring extrapulmonary TB, and that's probably conservative. That's the lowest of the 3 figures we have. Using the GULU data, 6.5% developed CPA in years after that, but because we've already got 8% of patients here, that's in a risk group of 24%. And then if we assume that TB is the commonest underlying disease and is 80% of patients, then we can assume that, but it may be conservative because you have a lot of COPD in Indonesia and quite a lot of asthma as well. And if we assume that 15% of these patients die every year or have surgery for an aspergilloma. So if you look at the number of TB patients with pulmonary disease who survive to the end of their first year of therapy, and you make these assumptions, then you probably have about 380,000 patients with CPA in Indonesia. And this figure is probably the second highest in the world after South Africa. This is a very large number of people. And we have not included in this the people where there was a misdiagnosis at the beginning of treatment because actually they didn't have TB, they had CPA. And we don't have a good estimate of that figure at the moment. It's coming, but we haven't got it yet. So these patients present quietly. It's quite a subtle infection. It's not always clinically very obvious. They have a cough. It's usually productive. They're a little short of breath. They lose weight. Sometimes they feel tired. If they cough up blood, it's often quite a lot of blood. So in TB, you can cough up a little blood, but usually it's just a streak or a little bit of blood. A lot of blood suggests chronic pulmonary aspergillosis. And some patients have chest ache or discomfort, occasionally pain, but it's usually more subtle than that. It's uncommon to have fever. Occasionally patients have fever, and if they do, that may reflect a bacterial infection on top of CPA, of TB. They may cough so much they have rib fractures, and they do get additional chest infections. So coughing up blood is a big clue to this diagnosis. And the radiological clues of pleural thickening, cavitation, and pericavitary infiltrates. This patient with sarcoidosis has a large single cavity. Usually they have multiple cavities. A pleural thickening, which is quite subtle, but it's definitely there. And then this additional shadowing underneath the cavity here, which is very, very typical. And in our 2016 guidelines for the diagnosis and management of CPA, we suggested that the radiologist should support CPA if there are features of cavitation, fungal ball, pleural thickening, and or upper lobe fibrosis. And so there's also in your country a need to reach out to your radiologists to tell them about these features so they understand them and they can add them to their reports as a differential diagnosis. This patient is illustrative. This young woman lived in Northern Ireland near Belfast. She came with a cough and was unwell. She was a smoker, and she has a complex soft cavitary infiltrating the left upper lobe, and a more like a consolidation in the right upper lobe. She was treated for TB. She did not get better. A year later, she has a lot of cavitation up here with pleural thickening, and this area underneath this pleura, which is very thick, and cavitation in the right apex with consolidation underneath that. 1 year after that, these cavities have got bigger. She has a fungal ball in this area. So now she clearly has chronic pulmonary aspergillosis or an aspergilloma, and she has a fungal ball on this side as well. And 4 months after that, these cavities are larger and the fungal balls are more obvious. So the previous terminology for this was a bilateral aspergilloma, and we used the term chronic cavitary pulmonary aspergillosis because there was no terminology in the literature for her first presentation, which is the beginning of this illness. And patients who have an aspergilloma have later stage disease generally. So these are what the aspergillomas look like if you take them out surgically. And we demonstrated in our center in Manchester some years ago, looking at this, that if you had no fungal ball, you survived much longer than if you had bilateral fungal balls. And even having a single fungal ball was not as good in prognosis terms. So aspergilloma is a later feature of disease. And so if you look at this CT, which is a fairly complex CT in a smoker, so you've got bully in the apex consistent with bullous emphysema. This patient previously had NTM infection, and this is an empty cavity, which is a feature of cured NTM, possibly on top of bullous emphysema. And on the other side, you have a cavity with multiple small areas within it and an irregular edge and a thick wall and pleural thickening. And this is all fungal growth inside the cavity. This patient from India had had TB twice, documented and treated twice, which is unusual. And then he had new shadowing with just a little bit of cough, but he was not much disabled because he was working very hard. There's no fungal ball in his x-ray, but he's got a lot of pleural thickening and contraction of fibrosis at that apex. Strongly positive Aspergillus IgG, but are normal inflammatory markers. So no inflammation in his lungs. And his CT scan shows this pleural thickening and an irregular area, fat ingress consistent with inflammation in the lung here. But a PET scan was done because they weren't sure of the diagnosis, shows a lot of pleural inflammation. And so this chronic pulmonary aspergillosis is an inflammation, if you like, of the pleura and the edge of the lung. And it's quite marked if you do this type of imaging, but not when you look at his own clinical features or inflammatory markers. So the differential diagnosis, as you know, is TB, NTM infection, but also ABPA can look like this, lung cancer can look like this, some cavitating pneumonias, Pseudomonas, Staphylococcus, Rhodococcus, nocardia, actinomycosis, and also very much relevant in your country, chronic pulmonary histoplasmosis, because you have a lot of this disease, probably not well documented. And then if patients have traveled to the Americas, coccidioidomycosis or paracoccidioidomycosis. And this is an example of chronic cavitary pulmonary aspergillosis in a man from Argentina who presented with, was treated for TB twice, which was the incorrect diagnosis. And then he had a laryngeal biopsy, which showed granulomas. And when they looked again, they found yeast, and then he had a strongly positive histoplasma antibody. So this is, again, antibody to histoplasma is important. We held a meeting in October to try and document the frequency of this disease and a plan for low and middle income countries. And this was the case definition that we came out of with that meeting, which was really quite helpful in terms of understanding the disease. And one of the features that you need to know is that Aspergillus cultures are usually negative in these patients. So here's a patient with contraction, having had chronic pulmonary aspergillosis for some years on the background of smoking and previous tuberculosis. And there is a fungal wall up here, which is difficult to see, but it's present, and lots of sputum, masses of sputum, but culture negative. You can do a bronchoscopy and look for Aspergillus antigen or galactomannan, and this study from Japan shows the sensitivity at about 70% and specificity about 80%. So it's a useful test, but it's not a perfect test in this context. The key test is Aspergillus IgG or precipitins testing. This is an old methodology which was developed in the 1960s at the Brompton Hospital. There are fancy new machines like this ImmunoCAP machine. In fact, there are about 8 different commercial assays with different sensitivity and specificity depending on the test and the control group. And the test that is now has been trialed in Indonesia successfully. Dr. Anna has led this with my colleague Chris Cosmidis and Prof. Retno and others. It looked at this lateral flow test, which was developed in France, released in 2018. And you take serum and you put it in the well, with some buffer, you wait about 30 minutes and it comes down and you get a control line. And if the patient has Aspergillus antibody, you get a positive test line here. So these two are negative, positive, positive. And it's really a very good test in our hands, and some data that I suspect Anna will present will also show this test to be useful in your country as well. So in conclusion, CPA is a common infection in Indonesia. It's probably significantly underdiagnosed. Patients are probably treated for TB, but they shouldn't be treated for TB in most cases. The problem from a public health perspective is that this discredits TB programs because patients come expecting to get better and they don't get better. And so if the correct diagnosis is made, this will be very helpful for patients and the TB programs. We do think radiologists should be reporting these patients as having possible aspergillosis or indeed histoplasmosis as another differential. IgG antibody should be routinely available to all respiratory clinics across the country. And there is a need to build expertise to both diagnose and manage these patients because they're not easy to manage. And so there's a real need for educational programs. And I'm delighted to today participate in your program today. Many thanks indeed.
Thank you, Professor Denning. The discussion or question and answer will be done later, so I hope you can still stay for us until the end of the session. Okay, we proceed to the next speaker, Dr. Chris Cosmidis, PhD. Dr. Chris Cosmidis, PhD is a senior lecturer in the Division of Infectious Immunity and Respiratory Medicine, University of Manchester. He's also a consultant of Manchester University NHS Foundation Trust. He finished his MD in Budapest and complete his infectious disease clinical training and also PhD in the US. Please, Dr. Cosmidis, you can present your topic, reason.
Good afternoon. Thank you for the invitation. Can you confirm you can hear me well?
Yes, Dr. Chris.
Dr. Cosmidis.
Thank you. So, thank you very much for inviting me. We're very lucky in Manchester to have the National Aspergillosis Center. It's a center that sees a large number of patients with chronic pulmonary aspergillosis. And as a result, we have significant experience here. I have seen quite a few patients with CPA, and I would like to share with you. Sorry. Should I continue? Sorry, but unfortunately, connection is not very good.
Maybe delay a bit, Chris. Okay.
Shall I continue? All right. So this is a typical patient that we could see. So this is a patient that I saw a few months ago. This is a 74-year-old woman with a diagnosis of COPD, which has been known for about 5 years. And she had a bad case of pneumonia about a year ago. She has quite unremarkable past medical history. She's not on any immunosuppression, and she presented with a productive cough, anorexia, and weight loss for 6 months. And this is her CT scan. As you see, there is a background of COPD, but also a thick-walled cavity in the right upper lobe here. But sputum culture has been negative, and we heard from Professor Denning how difficult it is to diagnose it sometimes because the cultures are negative. So this patient went on and had a bronchoscopy, and the galactomannan, which can be useful in those cases, was elevated at 2.2, and the Aspergillus IgG was also elevated at 117. So she was seen by us a few months later, and as you see, she had an up-to-date CT scan, and now there is what looks like a fungal ball in that cavity. So from the point of view of this specific patient, she doesn't have any specific risk factors for CPA. She doesn't have, she hasn't been on any steroids, not even steroid inhalers, although she was exposed possibly to fungus. So she was using compost and she was a gardener. So how do we help this patient? What are the questions that we should ask when we try to address this disease? So the questions that come to my mind is, first of all, which drug is the best to use? How should I start treatment? And the next question is, for how long? That is also another question that requires answering. So the question the patient will ask is, will she improve? And how would we assess that she has improved? Remember, this is maybe an elderly patient with COPD, so she may remain breathless. She may not improve so much. And the question that most patients ask is, after you treat me, will this come back? How do we know that it is gone completely? And finally, the question that comes to mind also is, do these patients have some underlying immunosuppression that we are missing here? Remember, this patient has never been on any steroids or even steroid inhalers, so why did she get this disease? And we always have to remember that Aspergillus is an opportunistic mold, so there may be some immunosuppression underlying that. But this is only one type of CPA that we see. There is really a very large spectrum of disease. Starting from on the left-hand side, you see here a patient with a nodule. So this, how it can begin. It can begin with a nodule, which may not cause any symptoms, but there may be, of course, the confusion with possible lung cancer. So these patients may have the lung nodules removed or biopsied. Then there is the picture of the simple aspergilloma, so thin-walled cavity, usually smooth-walled and with a fungus ball that may be stable for a long time, so you may not have to do anything. But these patients may have large volume hemoptysis, and this may require surgical excision. And on the bottom panel, you can see the pictures of chronic cavitary aspergillosis, so multiple cavities sometimes with aspergillomas, and sometimes some patients can have quite progressive fibrotic disease in the lungs. So I'll mainly talk about the bottom images here. These are usually the most severe diseases that are more progressive and require treatment. So should we start with the basics? Will these patients improve on antifungals? Or is it perhaps that this disease is kind of very chronic and giving antifungals will not make a huge difference? So do we need to treat CPA? So there's only one study that is randomized and controlled study. This is from India. So what they did, they compared itraconazole with standard of care in patients with CPA. And what they found was that giving itraconazole resulted in improvement both radiologically and clinically. Some patients remained stable and a few worsened, but without treatment, the majority of patients worsened over 6 months. Of course, as you see, there are small numbers of patients here. But this is the only study so far that has compared no treatment with any form of antifungal treatment. And this can give you an impression of what we mean usually by improvement. So, for example, on the top panel here, there is a aspergilloma that has got smaller after 6 months of treatment, and the cavity wall maybe is thinner. And on the bottom panel here, an aspergilloma that was present now has disappeared. But we definitely need more studies. So this is a study with more patients, and the way to do that was to do a multi-center trial, which was from France. And in this case, they assessed voriconazole. And they looked at the symptoms at 6 months and 12 months in various symptoms, as you see, related to pulmonary disease. And on the right-hand panel, you can see that the response rate is actually somewhat disappointing. So you can see that a bit more than 30% of patients only responded to treatment. Of course, it's really variable in this disease what we can consider as response. Sometimes it can be subjective, what the patient would report, but we would like to also rely on radiology. So in this case, they used global success as complete or more than 50% improvement in the radiological response. And as you can see here in the top, in the gray color here, only 3 out of 22 patients with what we call chronic cavitary pulmonary aspergillosis improved. So this is a very small number at 6 months. And on the bottom here, with the black color, were the patients with what we call chronic necrotizing pulmonary aspergillosis, and there was quite a more improvement in those patients. But going forward, this is the end of treatment. So they were allowed to continue treatment beyond 6 months. And actually, you could see that there was further improvement, ongoing improvement, if you continue treatment beyond 6 months. And I'll show you images to illustrate the differences between chronic cavitary disease and the chronic necrotizing form, which is another name for subacute invasive aspergillosis. So it's a form of invasive disease mostly. So you could see that continuing treatment beyond 6 months, you can see some ongoing improvement. So it's possible that longer than 6 months may be more beneficial. And these two images here from the same study illustrate the differences between those two forms. On the left-hand side, you see a thick-walled cavity with an aspergilloma. And this is a follow-on CT scan that showed that, of course, the cavity got bigger, but it's more thin-walled. And this aspergilloma probably has disappeared. But, of course, we cannot say that this patient is cured because the cavity is still there and maybe still having symptoms. Whereas on the right-hand side is what the authors here classified as chronic necrotizing aspergillosis. So these are patients typically more immunocompromised who develop the disease more acutely. They may not have cavities yet, they may be having infiltrates. So this is a form of invasive disease for which you can actually see cure because the cavities have not formed, there is not much pleural thickening. So these patients actually may have a better prognosis and you can cure them. But it's very important to address the immunosuppression if it can be reduced. But how can we objectively determine whether a patient has improved? That will help us have real good treatment outcomes for those patients so we can really more confidently say that they have improved. In this study from France, they focused on radiological response here. And they compared the clinical response, so what the symptoms, whether the symptoms improved, and they compared that with radiology. And what they found is what was important and what correlated very well with clinical improvement was the disappearance of a fungus ball or the reduction in the cavity wall thickening or the pleural wall thickening. But on the other hand, the size of a cavity or a nodule did not correlate with clinical improvement. So you can get enlarging size of a cavity, but the patient may be improving. So the size of the cavity in itself may not be a predictor of response to treatment, but definitely disappearance of fungus ball or a reduction in the cavity wall thickness is probably important. And that figure clearly illustrates that here. This is a patient with a thick walled cavity, and you can see after treatment, the cavity wall thickness is much less, and the pleural thickening as well is less, although the cavity may be bigger. So this patient clinically had improved. So that's what we can use as a response to treatment. Now, the difficulty, of course, would be with a chest X-ray that may be more difficult to ascertain, and sometimes we have to use a CT scan to get a better description of those subtle changes maybe on the cavity wall. But how do we correlate the clinical response with the radiology? And in different studies, they have used different criteria for improvement. This is a study from Manchester, and what was used as definition of clinical improvement was weight gain. So that's always a good sign in those patients. A lot of these patients complain of severe fatigue. They feel very tired, exhausted. So increased energy levels may help. Less breathlessness, although this, of course, could be difficult to always achieve if they have a background of COPD. And increased exercise tolerance. And conversely, there could be some symptoms that could suggest deterioration, especially high sputum load or worsening cough. And of course, hemoptysis is a major feature here. So here comes the question of how long to treat. And what has become apparent is this is a chronic disease, so you may have to continue for a very long time, but it has to be individualized. And this is a large series from Manchester, more than 100 patients that were assessed based on a quality of life score, the St. George's Respiratory Questionnaire, over 12 months. And this is a summary, a graph of the outcomes at 3, 6, and 12 months for all patients. And there are 3 antifungals that are assessed here. There is itraconazole, voriconazole, and posaconazole. And in each graph, with the gray color here, are the proportion of patients that improved. With white are the patients who are stable, and the in black here are the patients who deteriorated. And you see that over time, even beyond 6 months, even at 12 months, there is more patients who have improved. And this is true for voriconazole and posaconazole, whereas for itraconazole, it shows that maybe there is some more deterioration, which maybe is attributed to side effects. Therefore, it's not a direct comparison of the various antifungals, but you can see that overall, continuing beyond 6 months and maybe long-term could be a better option for some patients who actually continue to improve. And these are the guidelines that we have in Europe that in general, they recommend 6 months of antifungal therapy in those patients. Although for a subset of patients, it may be optimal to continue long-term, beyond 6 months and maybe long-term. And for the subacute invasive aspergillosis, the intention here is to cure the patient, so the disease can actually be completely eradicated, whereas in CPA, cavities potentially could remain long-term, so it may be difficult to completely eradicate that. So even with long-term treatment, sometimes a lot of patients will not respond. For example, this is a patient who had 8 months of voriconazole on the left panel, and you see even after 8 months of voriconazole, there is a new aspergilloma that has formed, and the cavity wall is thickened, which brings us to the difficulties with managing this disease, especially resistance developing on antifungals or ongoing immunosuppression, of course. There are quite a lot of studies on CPA, mainly case series, with itraconazole and voriconazole, but also some data on the intravenous antifungals like amphotericin B and micafungin. And as you can see from the response rate, it's quite remarkable that all of the studies have quite similar response rate at about 60%. So it's quite remarkable for me that even sometimes the authors will use different criteria. There is a 40% of patients who will not respond to antifungals. So that's what we clearly don't understand so much, and we have to do better. So, so it brings us to the question, which antifungal is best to use? Should we use itraconazole, voriconazole, or any other antifungal treatment? This is a direct comparison of itraconazole and voriconazole in patients with CPA. And what they found was itraconazole was associated with some adverse outcomes, like hospital readmission. So patients who had itraconazole were more likely to get readmitted to the hospital, or were more likely to then change to a different antifungal. This may be related to side effects of the drug. So the conclusion from this study was that voriconazole was preferable to itraconazole as the best treatment option in CPA. So the question that a lot of patients will ask is, what will happen when we stop treatment? So imagine you have a patient, you have treated them for 6 months, they're getting better, the radiology is better. Should we then stop treatment? And how to follow that? So this is a difficult question to answer unless you do a prospective study with different durations of treatment. But what we tried to do in Manchester was to retrospectively look at the patients who had their treatment stopped. So that this could have been because the doctor decided that they have much improved, or it could be because they had side effects. So we looked at more than 100 patients, and what we found was that patients who had bilateral disease, so bilateral cavities, were the most likely to have treatment restarted after stopping. So it's possible that bilateral disease is an indication of more severe burden or even of underlying immunosuppression. So these patients then may have relapse. So it may make sense if you have bilateral aspergillosis to be more cautious with stopping treatment, then you may want to continue for longer. So if you go back to that patient that I showed you before, my concern was, does this patient have some degree of immunosuppression that we don't know of? We would screen the patients for HIV, but they're more likely to be negative. They don't have any specific underlying immunosuppression. So what we have done in Manchester over the years is that we try to assess the immune function of patients. So you could do cytokine assay and look at whether they produce enough cytokine. So what we find as a pattern in our patients was that they produce substantially reduced interferon gamma on response to various stimuli. So for example, you see beta-glucan, a fungal antigen, or lipopolysaccharide, and the patients with CPA here in red have actually significantly reduced production of interferon gamma to all those stimuli. And that's also true with IL-17. So these patients have some form of immune defect that is maybe uncharacterized yet. So we have used interferon gamma in our center as salvage therapy in several of those patients. So we would do that if you have a patient with progressive aspergillosis who do not respond to antifungals. We can try interferon gamma as salvage therapy. This has been used also in invasive fungal disease. Interferon gamma is supposed to have also some direct antifungal effect in addition to the effect on the innate immune system. So how do we assess that? How do we see if this works? So ideally, we should have had a prospective study and look at the radiology before and after. But what we chose to do was to look at some outcomes that are really important for the patient. So for example, these patients get admitted to the hospital a lot, or they get a lot of exacerbations requiring antibiotics because they get secondary bacterial infections. So we looked at those outcomes because these were quite important and easy to measure. So to our surprise, we found that patients who received interferon gamma for at least a year had a reduced number of hospital admissions compared to the period before the interferon gamma was given, and also had a reduced number of acute exacerbations requiring antibiotics. Now, this is a really important outcome for the patients because ending up in a hospital, especially with severe lung disease, could result in death or severe morbidity. And also avoiding antibiotics courses is really important. So that was a really important observation for us, that interferon gamma resulted in reduction of those adverse outcomes. So there's really potential for this medication, for this immunotherapy option to be explored further. So, of course, antifungals are day-to-day concern for those patients, how long to treat them and which antifungal is best. But what other options do we have to help those patients? Of course, as you are aware, these patients could end up having very severe large volume hemoptysis, especially the ones with aspergillomas, and bronchial artery embolization can be an option that can help to temporarily at least reduce that. But resection, surgical resection, is what offers the chance of cure. Embolization is something we also employ in our center if needed. And as you can see, the outcomes are variable. So success can be achieved immediately, but a lot of the patients, approximately half of the patients, will have a relapse of bleeding, and usually within even a couple of months, and then they can have another embolization. And this is a lot better in patients with simple aspergilloma versus CPA. So simple aspergilloma is probably a lot easier to manage. And finally, we also are lucky to be affiliated with a large surgical center where I work. So we have also good experience with the surgical management of those patients. And as you see, the outcomes again are better with simple aspergilloma versus CPA. A lot of CPA patients may have relapse eventually. So to summarize, these are my objectives when I treat a patient with CPA. So my first goal is to try to improve the quality of life by minimizing symptoms. I think that we can achieve with antifungals. Hemoptysis is a major outcome that can result in mortality. So embolization or surgery can help. And as we have shown, if you don't treat the patients, they can deteriorate and lose lung function and even have a very poor quality of life. But with every patient with long-term antimicrobial treatment, of course, there is the problem of emergence of resistance and also antifungal toxicity. So these have to be minimized if possible. Thank you very much.
Very interesting information for us.
Halo. Halo, sekarang giliran saya.
Ya, Prof. Please proceed, Prof.
Oke, sama-sama. Assalamualaikum warahmatullahi wabarakatuh. Dr.
Proceed, Prof.
Dr. Elina, saya boleh mulai?
Silakan, Prof.
Ya. Dr. Elina, boleh saya bicara dalam bahasa Indonesia? Ini ada suara lain yang saya tolong di-share screen slide saya, Dokter.
Sudah, Prof. Silakan, Prof.
Ya, terima kasih. Topik yang ingin saya sampaikan adalah peranan dokter spesialis paru dan pusat mikosis paru di Indonesia. Next slide. Ya, kita di Indonesia saat ini mempunyai 1.248 spesialis paru yang terbaru datanya, yang tersebar di berbagai-bagai kota. Ya. Dan sebagian dari mereka adalah staf pendidikan dan training center, baik untuk mahasiswa maupun untuk spesialis. Next slide, please. Ya, ini digambarkan sedikit bagaimana sebaran dokter spesialis paru di Indonesia. Ini datanya dari Dr. Agus, Ketua PDPI, pada September 2020. Ya. Kelihatan bahwa yang terbanyak saya kira pasti di Jakarta. Slide berikut. Next slide, please. Next slide. Next slide, please. Next slide, please.
Prof. Anwar masih di dalam room. Mohon izin Dr. Ana, Prof. Anwar
Kelihatannya Prof.
tampaknya
Anwar
keluar.
terpental ya.
Oke, terpental tampaknya. Dilanjutkan pemateri selanjutnya atau kita menunggu, Dokter?
Dr. Alfian mungkin boleh dilanjut dulu ke pembicara berikutnya.
Ya, Dokter. Pembicara selanjutnya masuk ke sesi selanjutnya, Dokter Ana. Dilanjutkan ke sesi selanjutnya, pembicaranya Dokter Ana. Untuk sesi yang pertama sudah habis Prof. Anwar dan Prof. Retno.
Yang berikutnya Prof. Retno ya?
Iya. Prof. Anwar belum masuk di Zoom. Prof. Retno sudah ada di dalam room Zoom, sudah jadi co-host juga.
I do sorry, Professor Denning and Dr. Chris. This is the problem with the connections. I think Dr. Findra can help us to proceed to the next speaker.
Yes,
or maybe Professor Anwar Yusuf is already here.
Yeah, we can call him first, or maybe Prof. Retno will be the next speaker then. Prof. Retno, are you ready?
Okay, should I talk now?
Yes, please.
Can you? Okay.
Yeah, the sound is clear.
Just a minute, let me display this.
Yes, already seen.
Yes, but not yet displayed because this computer is a little bit problem. So I think without display, you see it clearly.
Yes, it's good, clear, Prof. That's fine. Yeah.
Okay. Okay. Thank you very much then for inviting me to talk in this occasion. And Assalamualaikum warahmatullahi wabarakatuh pada seluruh peserta. I would like to talk on the role of medical mycologists in Indonesia from the basic science to clinical application. Just a minute. There is a problem with my computer. Just a minute. Oh my. Okay. Oh my God. Just a minute, Findra. I think I have to do something with my computer.
Okay, Prof.
Okay, I think I'm ready now.
Yeah, okay. Right.
Okay. So before we are talking about medical mycology, we have to know what mycology is. Mycology is a branch of biology that is the study of fungus. We talk about genetic, biochemistry, food, and etc. concerning the fungus. And depends on the Oxford Dictionary, medical mycology is something that the science that deal with infection in humans, animals, and caused by pathogenic fungus. We talk about the concept, method, diagnosis, treatment of fungal diseases of human and animals. So to understand medical mycology, I think one needs to have sufficient knowledge of mycology, whether it is morphology, physiology, morphology, genetic, etc. So now let's talk about medical mycology. Medical mycology is focusing in taking care of mycosis. And to understand mycosis, we have to understand mycology and the fungus characteristic. First, fungus is heterotroph organism and get their nutrients by doing recycling organic materials, which also reflected when they invade human or animal. Usually it is in nature, but inside human body, it causes diseases and it is reflecting its ability as the recycler. It is a eukaryotic organism, a low virulence organism, except the true pathogenic fungus like Histoplasma capsulatum, but some of it are also saprophyte inside human body, and it needs a special consideration before we are establishing the diagnosis. So now I want to look back to the historical highlight of Indonesian medical mycology development. In Indonesia, actually mycology has been known since 14th century as written in the Kidung Negara Kertagama, which is written by Empu Prapanca. In there, he wrote the famous King Hayam Wuruk attended a festival which provided arak and tuak. And this arak and tuak was made based on the yeast fermentation technology. And the second thing that we know that tempe, a fermented soybean, is the daily consumption for Javanese for centuries. That's the start of medical mycology. I think it starts with the work of Muller in 1932 when he reported the first case of histoplasmosis in Java. Then the next year in 1933, Professor Boudin from Netherlands, India, a botanist, entered the Faculty of Medicine Stovia in Jakarta, and he has a long list of publications, including infection caused by black piedra or Piedra hortai, and he reported in the Mycopathologia in 1959. Then another thing that is a landmark in our medical mycology is phycomycosis. Now the name is Basidiobulomycosis, founded by our founding father, our founder of Department of Parasitology FKUI, Professor Lee Kian Yu. And now after this, I'm going to Indonesian archipelago. Indonesia is an archipelago consisted of 1700 islands separated by oceans, which is certainly an obstacle in the provision of healthcare. Let's see our map here. You can see here so many islands, 17,000 islands separated by oceans, and you can of course imagine that the facility in Jakarta is quite different. For instance, this facility in Papua. So, and another thing that I know that mycology laboratory is quite scarce in Indonesia. It is limited in big cities, even not every big cities, and mostly in the hospital. They have also microbiology lab, which is taking care of medical mycology, but I think they are only taking care about Candida because it is commercially available. This is the map made by the Asia Fungal Working Group, where I belong to it. We are doing a survey in Indonesia, in 7 countries, including Indonesia, and you see here that in our country, it's quite scarce medical mycology lab. In Jakarta, we have 4, but another place, for this such a big country, we have only another 4. So this is the result of our survey in Indonesia. You can see here that from 182 laboratory that joining the survey, only 11, which is having the medical mycology lab. And you can see here, most of them are not accredited, only 2 laboratory, which is accredited as a medical mycology laboratory. And all the laboratory in Indonesia, I think is not that complete, because the complete laboratory that can do investigation about morphology, about the susceptibility study, and have their own kit and house test or commercially kit available, it's only in Jakarta in Parasitology FKUI, but in another place this is not available. And I think because of this, we need to disseminate our knowledge for the benefit of patient and community. And this is the clinician response of Indonesian doctors. We did also survey clinician response in 7 countries, including Indonesia. And the clinician here is ID physician, hematologist, transplant physician, intensivist, etc. But it's only 17 doctors. And at the end of our paper, we are concluding that the survey is identified inadequacies in medical mycology training. Many countries in Asia, non-culture diagnostic access to antifungal drugs and local guideline is not available. There is a gap between the Asian countries, between, for instance, Singapore and Japan, which is very advanced, and Indonesia. We can say Jakarta is okay, but another place outside Jakarta, I can't say this. So, how about the role of medical mycologists in Indonesia? We are working on basic science, doing research that provide basic knowledge for use of medical mycology. Of course, not that much. Then we do also translational research, and we also applied our knowledge, helping the clinician to establish diagnosis and ultimately treating the patient. So another thing that we in Jakarta, in Indonesia, doing is capacity building. disseminate our knowledge on medical mycology. First, basic science. Basic science researchers work to find out the secrets of life, including fungus, and its interaction with environment. The result of their work can be used to understand various aspects of mycosis, such as pathogenesis, prognosis, diagnosis, treatment, and prevention. There is no commercial intention, only for the improvement of human life. And what we do in Jakarta is like this. We have cases of thalaromycosis, previously called penicilliosis, and we know that the most common cause of thalaromycosis is Thalaromyces marnivii. But we find a different thing. We find Thalaromyces arthrosuus is also the cause of infection in HIV and non-HIV patients. In these articles, we provide many things: data on the susceptibility, morphology, and molecular analysis. If you see the phylogenetic tree in the right side, you can see that we have Thalaromyces arthrosuus mostly, and only one Thalaromyces marnivii. My concern is Jakarta is not known as the endemic area for Thalaromyces, but Sumatra, yes, but no risk report from Sumatra yet. So I think we have to do something with this thing in Sumatra. And the other thing that we work on basic science is about cryptococcosis. Collaborating with many scientists from the world, and we then concluded that we have to talk about taxonomy of this Cryptococcus. And I think now we know that Cryptococcus is not only consisting of 2 species, but more than that, 7 species. And how about the translational research? This translational research developed based on the diagnostic needs in our laboratory. So I want to show you the first case, why then I work in this kind of research. This is a lady with HIV infection who was sent to the hospital, the Darmais Hospital, and she was consulted to dermatology and due to her skin lesion, and then to laboratory. And when I saw the patient, I saw this patient not only suffering from the lesion on her skin, but also saw mental alteration. So I think this must be a specific systemic process. Then I tried to do a kind of sample collection, a touch biopsy method, and then stain it with TIMSA. And this method, we are able to show that this patient suffering from cryptococcosis. This cryptococcosis then turn out to the systemic infection because we can isolate the fungus from the blood, and from the skin we can also isolate the samples, the fungus. And later on, this fungus is Cryptococcus grubii serotype A, Neoformans variety grubii serotype A. Based on this work, then we develop this touch biopsy method, a simple method that doesn't require sophisticated equipment. It can be applied in remote areas of our homeland that don't have any sophisticated laboratory equipment. It is easy and fast, the result. If there is a fungus, then less than 1 hour, we can have the diagnosis. It used the thick blood staining method for malaria, since Indonesia is endemic for malaria. The equipment is available across the country. Every laboratory person used to accustomed to this method, and there is so I think the equipment is available in every laboratory in our country which diagnose malaria. The only training necessary is how to identify the fungal elements, and that's also important. Then this method is useful for other systemic infection with cutaneous dissemination, histoplasmosis, thalaromycosis, candidiasis, etc. I can show you the result. I just write this result and learn to publish it. Maybe you can see it later. Then how about the clinical application? The duties of medical mycologists for patient management is determine the type of laboratory examination, determine suitable clinical materials, how to collect, how to send it to laboratory, and interpretation of laboratory results. And if further examination is needed, a detailed explanation to the clinician, how to take it, what kind of tests we have to explain to them, then they will understand. So it can be concluded that medical mycologist plays a critical role in the management of patients with mycosis. And this is the example of clinical implementation in a liver transplant patient. Patient of Dr. Karyanti from the pediatric department, a 4-year-old girl with 2 years liver transplantation, and she was admitted to the hospital due malnutrition. So while she was being treated in the hospital, she was suffering from pneumonia. She suffered from fever and also shortness of breath. She got ceftazidime intravenous, but no significant improvement. Then laboratory test also detects an Epstein-Barr virus infection and ganciclovir was started, but in day 10, she suffered from thrombocytopenia and ganciclovir was stopped. On chest X-ray, multiple node was detected and voriconazole IV was given for 2 weeks without improvement. Then we discussed the patient. I was invited the pediatrics and we saw the patient and we saw that the result of the laboratory test showed the bicytopenia, which is one important science, important laboratory result for histoplasmosis. And then on X-ray, on the next X-ray, the nodules in both lungs have multiplied and it was decided to do the GM aspergillus test, the galactomannan aspergillus test. The differential diagnosis is post-transplant lymphoproliferative disorder. And we saw here that the result of the GM test is 1.49 and the cutoff is 1. And we discussed again about this. This patient has received voriconazole for 2 weeks without any improvement. And we know that voriconazole is a first-line treatment for aspergillosis. But I told Dr. Karyanti, but the result of our study in the Department of Parasitology that 25 of patients with positive aspergillus were also positive for galactomannan histoplasma. Based on the clinical presentation, GM test, and peripheral blood results, we conclude that this patient suffering from histoplasmosis, even though at that time we couldn't isolate the fungus. And amphotericin was given, and on day 3, the patient showed significant improvement. And then the patient discharged after 3 months, submitted to the hospital. She have itraconazole, and last week she was in the hospital, and she is quite well. So I think this is the collaboration between clinician and medical mycologists that have been that give benefit to the patient and also for the doctor. Then the second clinical implementation is from Dr. Deviana from military hospital, Army Hospital. It's about the chronic pulmonary aspergillosis. A 60-year-old lady with recurrent hemoptysis looked ill and cachectic. And in 1998, she was diagnosed as pulmonary TB, treated and considered cured. But in 2003, again, she was suffering from TB with sputum acid was bacilli positive and again treated by anti-TB for 9 months and declared cured. Then in 2007, she has cough and bloodstream the first time, but this time the acid-fast bacilli is negative. She was given antibiotics, she feels better, and the diagnosis is residual symptom of TB. In 2010, she suffered from profuse hemoptysis. And again, she was considered as residual TB. And in March, the same thing happened, that she suffered from profuse hemoptysis and admitted to the hospital for 1 week, having antibiotic, but this time no response for the treatment of antibiotic. In May 2011, she was sent to our laboratory and we checked 3 days sputum and we can isolate Candida albicans and we have the Aspergillus antibody positive. Even though this is in-house, but still it has its benefit for the patient. And in July 2011, again we checked for the sputum and we have the Aspergillus niger and antibody again positive. And then we can isolate the Aspergillus fumigatus in 011 and based on many diagnostic information such as CT scan and pulmonary aspergillosis. What I want to tell you is this is the first case of confirmed CPA in our laboratory. And from then on, a study on pulmonary aspergillosis in the Department of Parasitology started. We have now the result of invasive pulmonary aspergillosis done by Dr. Anna when she did her PhD. Pulmonary aspergillosis. Then again, Dr. Anna started also working on chronic pulmonary aspergillosis. So I want to show you here that the result of laboratory work will be important for the future research in medical mycology. The work in our laboratory makes us then realize that we have so many problems of fungal diseases, not only Candida, which is very famous cause of infection. And now, since the condition of Indonesia is, you know, this is a big country with many islands separated by ocean, so we have to do mycology dissemination. There is a striking differences between laboratory in Jakarta, even with laboratory in Semarang, Central Java, for instance. If we talk about the Papua, it is there is more discrepancy between the laboratory. So we start to do the capacity building. We start to disseminate by capacity building and collaboration with societies. How to disseminate? We found a medical mycology organization, Perhimpunan Mikologi Kedokteran Indonesia, or Indonesia Association for Medical Mycology, was founded in 1989 by 11 doctors and vets, and we are now, and we work for the dissemination of this. We are hold a seminar, we hold a scientific meeting, and we becomes speakers in many places in Indonesia. And we also supporting government with collaboration with Clinton Health Foundation. We disseminate this medical mycology in Papua together with neurology. At the time I was invited to Papua, we are talking about cryptococcosis. And then we, again with the collaboration between PMKI and Clinton Health Access Chai, we published a guidebook for the diagnosis of mycosis in HIV. And Asia Fungal Working Group, we are the Asian Fungal Working Group, EFWG. We are conducting trainings in several ASEAN countries. We are conducting research and publish articles. And we are also collaborating with Parasitology Clinic Indonesia, because this is the first school of clinical parasitology, and mycology becomes the integral part of that education. And also I was invited to be a co-founder of the pulmonary mycosis at the time. And in our research activities, I did a research together with Professor Denning. We include capacity building, an effort to introduce our research and also mycosis diagnostic capabilities, especially for eastern part of Indonesia. So the conclusion of my talk is that medical mycology is a relatively young discipline, especially of course Indonesia, even though we know that some cases is already reported in 1930s, but we did many efforts to disseminate our knowledge, but tireless efforts are already done, but still we need more effort to bring benefits both for doctors and patients. And then the dissemination about mycosis is also important by taking into account Indonesia geographical and local condition, because we know we are quite different, of course, with Europe, which is it is only land, but Indonesia is islands with many oceans, and we need different method to disseminate our knowledge. A medical mycologist plays an important role in treating mycotic diseases. It has to be remembered that either helping or confirming the diagnosis or directing the diagnosis. For example, by explaining the type of the test, clinical materials needed for the diagnosis, we are helping clinicians in diagnosis and ultimately, of course, giving the suitable treatment for the patient. And based on the result of the work in the laboratory, various studies can be developed, and involvement of students ensure a new generation of medical mycologists. I think I'm closing now, and thank you very much for listening.
Thank you, Professor Retno. Now I would like to come back to Professor Anwar Yusuf to present his presentation. Professor Anwar, are you ready?
Yes, thank you very much. Can you hear me?
Yes, very clear.
So thank you very much. Indonesia, well, the role of pulmonologists and pulmonary mycosis center. Next slide, please. Next slide, please. Yeah, here is the dissemination of pulmonologists in many cities in Indonesia. Jakarta is the most available, I think. And next slide shows, next slide, please. Yeah. This is the, oh, okay. Among the cases that are frequently found and exposed to medical students and residents are pulmonary TB, of course, including MDR TB. Then pneumonia, bacterial pneumonia, and other pulmonary infections. And mostly bacterial, but recently viral also becomes very important. And then asthma and COPD, of course, and lung cancer and pulmonary interstitial fibrosis. And pulmonary TB is the most frequently found in clinician. And allow me to speak now in a little bit in Indonesia. Ini pulmonary TB ini agak aneh ini karena Departemen Kesehatan itu kok tiba-tiba pada tahun yang lalu mengatakan bahwa singkatannya menjadi TBC. Padahal di dunia semua sudah menggunakan singkatan TB. Kok cuman Indonesia yang pakai TBC? Udah gitu salah lagi. TBC itu kalau dipakai ejaannya benar bacanya adalah TBC. Kalau mau TBK, tapi dua-duanya salah. Jadi saya agak heran kenapa kok Departemen Kesehatan memutuskan seperti itu. Tolong nanti Dr. Nadia pertanyakan. Okay, next slide please. Next slide. Now, pneumonia, bacterial pneumonia is the most common. One among the diseases that all physicians must be able to treat. So normally, every specialist believes they are able to diagnose and to treat. So they are not consulted to pulmonologists unless there are problems in the result of treatment or there is accompanying problems. Now, viral pneumonia are recently very popular with the outbreak of SARS, swine flu, and recently COVID-19. Next slide. Now, fungal pneumonia or pulmonary mycosis are hardly found, especially when awareness is lacking. Many researchers have shown that pulmonary mycosis and fungal-related pulmonary problems are far more frequent than we think. I think that has been shown by Dr. David Denning just now. Next slide. So therefore, it is important for pulmonologists to recognize the factors for these conditions so they can take actions for making diagnosis and decide the right treatment. Next. The most common fungus related to pulmonary problems are Aspergillus and Candida. And pulmonologists are supposed to recognize which fungus may play a role in the condition they are facing. Next slide. Yeah, so Candida-related pulmonary problem, usually Candidemia are together with some pulmonary condition. It's the most common problem in severely ill patients in the ICU, and fever is the most frequent sign. By radiologic picture may have become better or negative. Blood culture may be negative or for bacteria. Blood culture for Candida must be performed, though the result may be negative unless repeated several times. And this case treatment with echinocandin is give the best result. Next, please. Now, we come to Aspergillus-related pulmonary problems. There are 4 types of pulmonary problems related to Aspergillus. First is invasive pulmonary aspergillosis. Number 2, chronic pulmonary aspergillosis. Number 3, allergic bronchopulmonary aspergillosis. And 4, aspergilloma. But in my understanding from Dr. Cosmo's lecture, as aspergilloma may be part of the chronic pulmonary aspergillosis, if I understood him correctly. Next slide, please. Yeah. IPA and CPA may need special attention in diagnosis and treatment. ABPA may show symptoms and signs of asthma, therefore may be misdiagnosed and inadequately treated as common asthma. And aspergilloma is the most easily recognized form. Next. Next, please. Yeah. Now, CPA presents similarly to TB with indolent respiratory or constitutional symptoms and result in slow destruction of lung tissue, enlarging cavities and fibrosis. The global burden for CPA prevalences following pulmonary TB is quite big, complicating, can be following pulmonary TB, can be complicating ABPA or sarcoidosis. Next. Most CPA cases occur in Southeast Asia, the Western Pacific, and Africa. So where the prevalence TB is the highest. Next. Okay, next. Yeah. So this is the chronic pulmonary aspergillosis in TB patients. The number of CPA cases is about 83,000 in Indonesia. Only a minority with suspected TB have confirmed disease, especially among the HIV negative. CPA is a common important differential diagnosis, and more often than 300,000 cases of allergic bronchopulmonary aspergillosis, except from 13 million estimated asthmatic patients in Indonesia. Next. Now we come to the role of pulmonologists. In my opinion, the most important role of pulmonologists is to suspect, because if you don't suspect mycosis, then you do nothing to confirm it. And the most important is the awareness of the possible existence of fungal infection. And then also to prove using specific tests that was already described by Prof. Retno just now. And of course to treat, and to treat properly according to the infecting fungus due to the history and the laboratory findings. Next slide shows, I think, yeah, these are, now, these are conditions where we have to think of invasive fungal infections. That is immunocompromised patient. We can have a Candida, Aspergillus, and so on. And especially for candidemia, there are several major risk factors that is described in this slide. In this right-hand side, we see that there's several conditions that can enable patient to have candidemia. Next. Next slide shows some conditions that may be followed or by aspergillosis, which is hematological malignancy, pulmonary disease, already existing pulmonary diseases like TB or bronchiectasis or COPD, and then organ transplantation, which is still quite rare in our country, systemic disease as diabetes, and solid tumor, AIDS, and unknown. Yeah. There's some data from Korea that I think we can use for us to make us suspect the evidence or the existence of candidemia or aspergillosis. Next. Now, what is the role of pulmonary mycosis center? Next. Now, these are some X-ray picture that may be difficult for us to make diagnosis because it can be bronchiectasis infected, because it can be lesion of tuberculosis, chronic tuberculosis. Just next. So if you don't suspect and you don't do anything about it, this is some guidance that have been made by PDPI, Indonesian Association of Pulmonologists, on pulmonary mycosis. Next, click please. Yeah, revised in 2017, I think. So that's why I think a pulmonary mycosis center is considered important. Next. Next, please. Yeah. For my knowledge, at this time, we have only one first pulmonary mycosis center, which is in Persahabatan Hospital. And of course, as already described by Prof. Danning, we need to perform multi-center studies like epidemiological, clinical laboratory in Indonesia, in pulmonary disease patients and critically ill patients and HIV infected patients. I think we have to get this data of such patients' condition. Next, please. We also need to do molecular studies and diagnostic strategies and research collaboration is highly needed. As already described by Prof. Retno, the collaboration between clinician and clinical mycologist is a very big help for diagnosis and treating the patients. Next, please. So by Pulmonary Mycosis Center, we may help doctors, residents, and pulmonologists to recognize earlier the possibility of pulmonary fungal infection and fungus-related pulmonary cases. So if we recognize earlier, then we can diagnose earlier and so treat earlier, as already described by Dr. Cosmo. Next. Now, future strategy is that we need continuous effort to is highly needed to overcome the problems, gap of knowledge, limited diagnostic facilities and management, improve the capability already described by Prof. Retno, strengthening the collaboration, clinician and laboratory staff. Then it is made possible by the existence of pulmonary mycosis centers, broaden and increase the research collaboration and research groups like we already have now. Next, please. Yeah, there are some issues on the professional and ethics. So modern medical practice is evidence-based, and evidence is derived from research earlier within the institution of carried out at other institutions and assessed through publications. A practitioner who engages in research tends to practice better medicine because the intellectual stimulation provided by research activities. Next, please. Now, but we do have to balance between clinical care and clinical research because the primary role of doctor is to treat the patient. Research is a secondary role and should never be allowed to interfere with the patient care and patient safety. The most important consideration in research is patient safety and rights. Research should pose minimal risk and should be carried out after obtaining informed consent following a full disclosure. Conflict of interest situation in publication. So the best protection is full disclosure for the interest of the researchers. Next. So a doctor need humility and of course sound medical knowledge to be able to translate the knowledge into effective care, to be able to work in a system or a team and with the enough clinical skills so we can give high standards of professionalism. Next. Yeah, these are some activities that we have had already. Next, please. Yep. Also, some occasions that I think have already described by Prof. Retno. Next. Yeah, that's me. Thank you very much for attention, and maybe we can go on with the discussion. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Professor Anwar Yusuf. Let us proceed to the discussion. I already have collected some of the question here. First is for Dr. Nadia. That's one question asking what is the support of the CDC to diagnose and also treat for the treatment of aspergilloma non-HIV patient.
Yeah, I think that's something that we have to decide And of course, the mechanism of the drug to be able in the market is the pharmaceutical should register it to Badan POM, and with that the drugs will be available. But the issue is if the amount is too small, usually the pharmaceutical company they don't feel it's something that they would like to go to the process for the registration, because the registration itself, it will take some times and of course some resources. So I think why we procure some fungi drugs currently under HIV program is because of the number that will be used is still very in a small number, which the pharmaceutical company, they don't want to register this drug. So that's my answer, Bu Erlina.
Yeah, the second question for Ibu Nadia is there any step to support the human resources for aspergilloma diagnosis, since there are government facility that can able to do diagnosis for aspergilloma, especially the human resources?
Yeah, I think if the issue is the human resources, of course we cannot produce human resources in a short time, and we always know that in the at the health service level, the human resource always an issue. So I think first thing what we can do is we train this any staff or any human resources we have to be able to exam for this diagnostic. And then the second one, we need to have a simple methods for the testing. I think those two things, Bu Erlina, I think one of the shortcut way to make the diagnosis or the laboratory testing available across the country.
Okay, thank you, Bu Nadia.
Boleh saya tanya kepada Ibu Nadia?
Ya, Prof.
Yes, Prof.
Ya, begini, Bu Nadia, saya tidak tahu ya berapa banyak pasien HIV yang juga didiagnosis menderita jamur. Sehingga saya pikir ini nggak tahu betul atau tidak, obat-obat anti jamur yang tersedia untuk pasien HIV saat ini agak kurang digunakan. Ya. Pertanyaannya, apakah boleh obat-obat tersebut kalau dibutuhkan oleh pasien yang bukan HIV? Ya. Karena seperti amphotericin B itu kan sulit sekali didapat. Saya dengar itu ada tersedia hanya untuk pasien HIV. Itu. Jadi mengurangilah sedikit diskriminasi bagi pasien-pasien yang bukan HIV.
Ya, Prof. Jadi mungkin bahasa aja ya Bu Erlina ya, boleh ya, Prof. Jadi mungkin Prof izin karena kami membelinya untuk penggunaan tentunya pada pasien ODA, tentu kalau secara akuntabilitas kami harus mempertanggungjawabkannya untuk penggunaan ODA, ataupun nanti distribusinya harus dengan melalui PDP, artinya melalui klinik-klinik yang memberikan ARV. Nah, saya juga tidak tahu Prof, kira-kira kalau misalnya nanti ini kita memang banyak temukan atau menjadi salah satu yang akan direkomendasikan panel ahli tentunya kepada program tuberkulosis untuk juga mungkin mengadres masalah-masalah ini, mungkin ini bisa menjadi salah satu yang kita bisa usulkan, Prof. Sementara sih kalau memang kebutuhannya banyak di luar pasien daripada HIV ini secara akuntabilitas ini Prof yang mungkin nanti akan menjadi isu. Tetapi ya itu tadi Prof, kalau memang kita akan kaitkan dengan tuberkulosis mungkin ini masih memiliki ruang, karena kalau kita bicara penyakit khususnya penyakit-penyakit terkait jamur ini memang nggak ada di dalam
nggak ada, iya, nggak ada datanya.
Iya begitu Prof. Cuma mungkin nanti Komli bersama Jetset atau bersama ini bisa merekomendasikan Prof. Itu saja Prof.
Yeah.
Baik, terima kasih.
Terima kasih, Dr. Nadia. The next question is for Professor Denning. There are many questions for you, and some are similar, mostly about how to diagnose CPA properly. Since it is, do you think it's the right time to diagnose CPA and TB patient? Is it during the TB or post-TB? And also, what is the most clue to screen that this is CPA patient? Is it when we found the thickness of the pleura or just cavitation? There's a question already being answered by the chat, but you still can repeat this. Please, Professor Denning.
Yeah. Okay. So very good questions. So the first thing is in patients who don't have confirmed TB at the beginning, when they first present, it's very important to see whether actually TB is the right diagnosis. Sometimes it's not the right diagnosis. And so patients who don't have confirmed infection, at that point, it would be appropriate to consider aspergillosis, probably with a CT scan to check whether there's a fungal ball or material within a cavity that looks like fungal material, do a sputum culture or 2 or 3 for fungal culture, because fungal culture is more sensitive than bacterial culture, and do an aspergillus antibody test as well. Probably about 10% of the patients who are thought to have TB don't have TB. So this will mean that you don't inappropriately treat these patients. During the course of TB treatment, even if it is confirmed TB, if patients are not improving well and the radiology is not improving, then that's also, you need to check for aspergillosis during the course of TB treatment. Usually this will be between 3 and 6 months after starting therapy, because early on it takes time to recover, even with anti-TB therapy. I suggest a chest X-ray is done at the end of treatment in patients who have severe disease, because if you have cavities, then those cavities, that's a baseline for future radiology if the patient comes back. And then patients who who come back with possible relapsed TB or other symptoms of breathlessness, coughing up blood, etc., after they finish TB treatment, that's a group that where there's probably a high risk of aspergillosis and a less risk of TB. So that's an important group. So there are 3 stages. We have had a small number of patients with TB and aspergillosis together in Manchester, and this requires a change in the TB regimen. Azoles cannot be used successfully together, so you would need to stop the rifampicin and give a prolonged course of other therapy plus antifungals if you made the diagnosis together. And if they're very ill, it may be necessary to give them amphotericin or echinocandin for a short period. This group have shown that the outcome is determined by treatment of the aspergillosis. So if you only treat the NTM and not the aspergillus, the patient has a higher chance of dying. So they also need, the aspergillus needs treatment as much as the NTM, and possibly more than the NTM in that context.
Professor Denning, there is a question on which one is the most important, thickness of pleura or cavitation in order to screen for CPA.
Sorry, I didn't understand. What's the most important?
If the screening for CPA, if we see pleural opening, is it have a better sensitivity than cavitation?
Sorry, I'm still not quite understanding. On the radiology, the most characteristic features are cavitation with a thick wall and with pleural thickening. Those are the most characteristic features of CPA. Sometimes you get a fungal ball or a fluid level in the cavity, and you can have multiple cavities or single cavities. And you can have patients who present just with nodules or masses, which is all aspergillus as well, although that's less common and usually diagnosed histologically because of the concern about lung cancer.
Okay, Prof. Denning, there is also a question on which one is more sensitive of diagnosis. Is it X-ray, CT scan, or culture? Because there are more cultures and culture is not in many cases.
So culture is often positive, but not always positive. The Aspergillus antibody is the most important test. If you do a bronchoscopy and a BAL, then the culture has a low yield, but Aspergillus antigen has a much higher yield in that group of patients. Sometimes microscopy is positive as well for fungal hyphae. So you cannot exclude the diagnosis just with a respiratory culture. It's not sensitive enough to exclude the diagnosis of CPA.
Can I ask Prof. Denning, how does the fungus grow in the lung? Does it do invasion or just growing on the surface of the alveoli or of the bronchi?
It grows on, usually it starts to cause a cavity. So sometimes you have a pre-existing cavity, which is in communication with the airways, and the Aspergillus goes into that cavity and grows on the surface of that cavity. And the cavity gets bigger, and you can get new cavities forming next to it as well. But it is a surface growth, you're quite right. It's not invasive in the sense that if you do histology, you can see fungal hyphae, but it causes a progressive cavitation and inflammation. So it can look like you have invasion because the radiology changes over time, but it does that very slowly with this surface growth and damage to the lung around the cavity, effectively.
So that's why antibody test is more important than antigen test, right?
That's right, in blood in particular, yes. But it's
Thank
not
you.
an easy diagnosis. Well, sometimes it's easy. If you have a big fungal ball, it's easy, but usually it's a difficult diagnosis. So multiple tests are often necessary. And so you do culture, you do microscopy, you do antigen, you do antibody, and sometimes you can do glucan, although glucan is not a brilliant test either in these patients.
Thank you.
Okay, thank you, Professor Denning. Next, there are three questions for Dr. Chris Cosmides. Yeah. First, we found asymptomatic CPA. Should we treat with antifungal? And second is there any report of antifungal resistance against aspergillosis? And the third one is, what is the choice of drug for patients that unrespond to voriconazole?
So, if I heard correctly, the first question was about asymptomatic CPA. Is that right?
Yes.
If we treat those patients. So asymptomatic CPA sometimes can happen. So maybe coincidentally, a patient can have a chest X-ray and you find some lesions. So if they're asymptomatic completely, it depends how extensive is it as well. So usually you can observe it, but you have to follow the patient with serial X-rays. So if it's, sometimes you can have a simple aspergilloma that can be just stable. And if you have serial X-rays, it doesn't change. The patient has no hemoptysis, no symptoms, you can observe it. But if you see progression, sometimes you can see progression even before any symptoms at all. So in that case, you probably should treat the patient if you see. So I think the key is serial X-rays to see if it gets worse, and close monitoring of the patient. Then the next question was what to do if voriconazole doesn't work.
Yes.
So in reality, unfortunately, we have to change between different antifungals. That could be because of side effects, or it could be because of resistance developing. So resistance, unfortunately, is relatively common in this disease. This is in contrast to invasive aspergillosis, where it's unlikely to see resistance developing on treatment. But in these patients where you have the large cavities and large aspergillomas, they have a high burden of fungus in there. So studies have shown that if you analyze the aspergilloma, you might find different groups of aspergillus in there. So they could mutate, become resistant. So it's a good environment for the aspergillus to become resistant. So unfortunately, resistance can develop during treatment. And over the years, we have seen that in Manchester. So what to do then? Unfortunately, you would have then to rely on intravenous antifungals. But what's important is to try to prevent that from happening. So you have to give the right dose of treatment of antifungals. Check the levels if you can, especially with itraconazole and voriconazole. So it's important to get good therapeutic levels early on. And then consider surgical resection is another approach. If you have resistant disease, you have to think about that as well. But it's clear that we don't have enough treatment options, unfortunately, in terms of antifungals, as you are all aware. We don't have that many antifungal classes to use.
Thank you, Dr. Cosmides. Now we proceed to Prof. Ratno. There are two questions, Prof. Ratno. First, how is the role of doctor in health facilities for early detection of fungal disease? And how can we build the national database for fungal infection cases in Indonesia?
Thank you, Dr. Erlina. I try to answer it. If I have to make a mistake, the first question is how to make the database of fungal infection, and then how to diagnose. Is that so?
Yeah, how is the role of doctor in health facility to perform early detection of fungal disease?
I don't get it because
yeah, can you answer database and also how to detect the primary health center?
How to make the database of mycosis?
In the primary health center?
Okay, I try to. How to make the database in the primary health center? Is that so? I think it depends. I think it depends on the
database.
Yes, Findra, what do you mean?
Of mycosis. Database of fungal cases from fungal.
Okay, I write some question here about the database of my. Yeah, okay. Okay, the database.
The database of how the
I didn't get it. That's, I think I write
some
cases.
No, Findra, I couldn't understand because it's echoing here. But I read some questions. It's about the database to know. Is it about cancer? Is it superficial infection?
How to build the national data for election? Comes to the national.
Okay, can I continue?
Please, Prof. No. Yes, please, Prof.
Okay, if you want to make a database of fungal infection, that depends on the fungus. You want to make dermatology, then you make the, of course, database of dermatology and superficial cancer. If you are going to have database on the invasive fungal infection, that we talk about the candidemia, we talk about the invasive aspergillosis, we talk about the histoplasmosis or paromycosis. So how to do it? Of course, you have to survey. And what kind of survey you do? If that's, of course, okay. Okay. Should I leave first and then join again the meeting? So I want to give you an example then. If we talk about the chronic aspergillosis, what Dr. Findra did and Dr. Anna did, it's okay. We can do using the laboratory methods such as the IgG detection, and of course we have combined that with the clinical sign and symptoms. Then, if you want to do it across the country, then you have to do it across Indonesia. We have to ask the help of the Ministry of Health. Otherwise, it will be too expensive, and the effort is so high if we want to do it across the country. But if you want to have a complete database, then you have to do it. Of course, this is the business of the government. Not we help because we have the competency, the capability to do the diagnosis. But because Indonesia is this big and the local condition is quite different with Jakarta, so I think we have to collaborate government to do this. If you want to have a database of across this country. If not, then you can do it for the Jakarta, for instance, as we do here. We have the data of aspergillosis. We don't have any proven data of invasive aspergillosis because we couldn't do a biopsy, but we have the probable based on the probable diagnosis using the clinical data, the laboratory results, and also the galactomannan test to do the study. So I think it already published, and you can read it. And what is the next question? Is how to build a mycology laboratory? Is that so?
Yeah.
Yes, Prof.
Yes.
Yes, Prof. Retno.
Okay. I think because this is for Indonesian people, I will answer it in bahasa Indonesia. Dalam mikologi, kita punya metode yang disebut conventional method. It based on the morphology, it based on culture, and it based on the direct examination, microscopic examination. Jadi kalau kita mau mendirikan laboratorium mikologi, mulailah dengan sesuatu yang sederhana. Mulailah dengan conventional method. Dengan conventional method, we can diagnose many things. If you don't have a sophisticated laboratory, then do it with things that you have. Saya pernah mengatakan kepada seorang dokter, if you don't have laminar flow, if you don't have sophisticated equipment, then why don't you use just a piece of glass, just put it on the table, then you can work on it. And then that glass is easily disinfectized if you are finished with the work. Mulailah dengan pemeriksaan langsung. That means you mastering the morphology of the fungus. Then continue the culture, and you have how to identify the fungus. Candida now is many commercially available Candida for identification of Candida, but still there is a traditional method that you can use. So you can start with that. If you are already mastering the conventional method, then you can continue with the advanced method, such as molecular-based laboratory. But that's later after you mastering after you are ready with your lab. Because untuk mendirikan laboratorium mikologi sebetulnya bukan sesuatu yang sulit. Yang perlu dilakukan adalah training untuk mengenali paling tidak morfologi terlebih dahulu. Start with morphology, then you can continue with your laboratory. And even though it is very simple, it will help the clinician to understand, help the clinician to establish the diagnosis. I think that's what I have to say now. Thank you very much. Terima kasih, Dr. Erlina. Silakan.
I would like to thank everyone. Since we do not have enough time, I would like to end this session. Thank you, everyone, and I hope that all that we discussed will be useful for the audience. Thank you very much to Dr. Nadia Tarmizi, to Professor David Denning, to Dr. Chris Cosmidis, Prof. Retno Wahyuni, and Prof. Anwar Yusuf. Thank you very much, and I would like to proceed with the second session. I will pass this to Dr. Findra. Dr. Findra, please, the time is yours. Thank you, everyone.
Take a picture.
Thank you very much.
Take a picture first, Doctor.
Yeah, let's take a picture for the documentation. Okay.
Okay, thank you. Enough.
Okay. I pass this to Dr. Findra. Please, Dr. Findra, you can lead the next session.
Thank you, Dr. Erlina, for your time as a moderator. We can proceed to the second session with the topic research highlight from Pulmonary Mycosis Center. Are you ready for the new challenge? We have 3 speakers here. For the first one, I welcoming Dr. Ana Rozaliani, the head of Department Parasitology Department Universitas Indonesia, and also she is the lecturer in clinical parasitology, biomedical science, infectious disease, pulmonology, and respiratory medicine, Faculty of Medicine, Universitas Indonesia. Time is yours, Dr. Ana, please.
Thank you very much, Dr. Findra. I hope my sound is quite clear. So in these short occasions, I would like to share our work on the multi-center study on the point of care testing for the diagnosis of chronic and allergic aspergillosis. We know that from the previous presentations that pulmonary aspergillosis is increasingly recognized worldwide, and the disease is quite varied from allergic type disease to acute life-threatening infections. And pulmonary TB is one of the most important underlying disease for pulmonary aspergillosis. We see here in these pictures from the WHO Global TB Report 2020 that Indonesia is one of the countries that have three high burden country lists for TB, HIV, and MDR TB. So this is quite unfortunate actually for us, and pulmonary TB infections is one of the most important underlying disease of CPA. And then as Professor Anwar stated in these previous presentations, that Indonesia have around 83,000 cases considered in Indonesia, and among more than 562,000 of total and new relapse TB cases, only almost only half of those cases had a bacteriologically confirmed. And so that in this patient, CPA is in important differential diagnosis, because the clinically characteristic radiological and routine laboratory tests sometimes it is not quite clear. So we see the diagnosis scheme of the CPA actually consisted of 3 parameters. The first is the diagnosis of CPA is a combination of some characteristics. The first one is the consistent appearance in radiologic imaging or thoracic imaging, the direct evidence of Aspergillus infection or an immunological response to Aspergillus species, and the third one is the exclusion of alternative diagnosis. The second parameter that we have to try to document it, that this finding must be present for at least 3 months, and the patient usually not immunocompromised. So the challenging diagnosis of CPA that we are facing is that data on pulmonary aspergillosis in Indonesia are still scarce, and some obstacles in diagnostic pulmonary aspergillosis are limited awareness of the disease, non-specific symptoms, poor sensitivity of culture, and lack of molecular diagnostic tests, as well as specific serology. So that's why we need the faster, easier, and more accurate diagnostic methods to deal with diagnostic problem. We hope that we can control unnecessary antifungal use and prevent resistance. We are quite fortunate that we have the opportunity to have the multi-center studies in collaboration with University of Manchester to conduct the point of care testing for the diagnosis of pulmonary aspergillosis. One of the methods is based on the lateral flow assay and immunochromatography test. And this is the test that actually described by Professor David Denning. And this is our work in collaborations with the Universitas Indonesia and University of Manchester, supported by Ristek Dikti and Medical Research Council UK, and in this Newton Fund scheme. And we have ongoing study on point of care test for diagnosis of chronic and allergic aspergillosis. We are almost finished the first period of our make of the COVID-19. We are quite unpleasant that the second period for the allergic aspergillosis study is a bit delayed for these situations. And the specific opportunities towards improving the diagnosis of Aspergillus-related disease in limited facilities is by point of care testing of IgG in blood and rapid identification of Aspergillus antigen in biological samples, as well as IgE testing for ABPA. We are doing this study in this the end of the years. So we would like to thank us and colleagues in that hospitals that participate in this multi-center study that consists of the TB patients populations and asthmatic patients, and we are happy to have these collaborations with the networking with the Indonesia Society of Respirology, Parasitology Department, as well as the other specialists. And finally, we have finished our work and published a part of the results on the paper of Journal of Fungi in at the end of this year's in chronic pulmonary aspergillosis in post-TB patients in Indonesia, and there are 22% of the 90 patients that met the criteria for CPA, and the LD biotest was positive in almost 80% CPA patients. But this is only a part of our works. Actually, we'd like to finish the rest of the study in the next years. And this is the publications of the Dr. Findra Setianingrum works with our colleagues from the Manchester with Dr. Rina and Professor David Denning, and we are very happy that this data will be the first data about the pulmonary mycosis. And this is the previous study in 2018 about the CPA in active pulmonary TB patients in Jakarta. We have about 60 patients, and we use the Aspergillus IgG with ELISA base. And the other ones is the study also in 2018. In this study, we perform almost 40% patient met the criteria for CPA. But this is only part of the data that we have to be aware, and we have to still going on to work on these problems. So that's I think that's part of our study, and we are very, very thankful for the support of the colleagues from those hospitals surrounding in Jakarta. And here we are very laboratory here. Professor David Denning and Dr. Chris Cosmidis here, Dr. Rina, as well as the other colleagues from the Japan and from the Asian Fungal Working Group, where the Prof. Retno is one of the board in those organizations. And this is part of our research team, the undergraduate medical students, and we try to ask the participate in our study, and this is a very nice collaborations with the students, and this is part of the team where Dr. Jamal work on. And the last is we have to thanks very much to the person or to the our member in the research team that work our study will be beneficial to improve our diagnosis quality and management in Indonesia. Thank you very much. I think that's my share about our work. So, Dr. Findra, I finished my presentations.
Yeah, thank you very much, Dr. Anna Rosaliani, for the presentation. Now we move to the second speakers in this session, Dr. Jamal Zaini, PhD, consultant pulmonologist, will have a topic about detection of IgG-specific aspergillus in lung cancer patients. So he is a head of thorax oncology division, Department of Pulmonology and Respiratory Medicine, Faculty of Medicine, Universitas Indonesia, Persahabatan National Respiratory Referral Hospital, Jakarta in Indonesia, and also head of Pulmonology division, University of Indonesia Hospital. Time is yours, Dr. Jamal, please.
Thank you, Dr. Findra. Is it okay, the sound?
Yes, it's very clear.
Okay. Thank you, Dr. Findra, and thank you, Professor. I would like to present our project about the burden of pulmonary mycosis among lung cancer in Indonesia. As we know that lung cancer is one of the deadly cause of death in cancer. This is men and also in women also. In Indonesia, the mortality of lung cancer is number 1, but in women is around number 5 or number 7. But it is clearly that lung cancer is one of the problem in Indonesia. As we know that the risk factor for lung cancer is smoking, and in Indonesia we have data from 2011 that 67% of adult male has a history of smoking, tobacco smoking. And as the data also say that it is predicted that within 30 years, there will be an increase in lung cancer death and also morbidity in, related to smoking. At least from here, we showed it is shown that smoking consumption is very increasing in Indonesia, and later on, around 30 years later, I think we will find many lung cancer cases in Indonesia. And the treatment option for lung cancer, usually surgery, radiotherapy, chemotherapy, targeted therapy, and also immunotherapy. Based on this, we know that lung cancer has a risk of pulmonary infection. First, it is we divide into 2 different groups: therapy-naive lung cancer, and it has a impaired immune response, and usually they have a comorbidity like COPD and low nutrition. In cases with treated lung cancer, we have also the impaired immune response due to the lung cancer therapy and also the effect of disease progression in lung cancer itself. We know that there is a spectrum of pulmonary aspergillosis infection. In lung cancer, we don't know which part. The most probable is chronic pulmonary aspergillosis or aspergilloma. That's what we want to evaluate in this project. There is data from MD Anderson that IPA in solid tumor is getting increased, and the risk factor is COPD and also radiotherapy. And also there is a data from Journal of Hungary this year that CPA after surgical treatment in lung cancer is also increased. And recently, I think a few years ago, that we found that Aspergillus infection is also found in tyrosine kinase inhibitor treated patient, and also with nivolumab or immunotherapy of lung cancer. So many aspects of treatment in lung cancer has increased risk of pulmonary Aspergillus infections. This is the title of our project, Potential Burden of Pulmonary Mycosis Among Lung Cancer in Indonesia. This is a preliminary study. We do the in Persahabatan Hospital. We screen cytohistologically confirmed non-small cell lung cancer, therapy naive. We did the induction, sputum induction with 3% of natrium chloride inhalation, and we did also the culture fungus and did also the ELISA specific IgG aspergillus. What we found is 77 evaluable subject, 75% were adenocarcinoma, 25% squamous cells, I think, sorry. And unfortunately, we didn't find any cavity as a sign of aspergillus, but most of them we found nodules and consolidation and mass in the CT scan. And 20% is EGFR mutated lung cancer. And what we found is very interesting, I think. This is our first Aspergillus fumigatus, Aspergillus flavus, and Aspergillus niger. We found this kind of fungus in the sputum of our samples. And not only that, in this sputum, we also found more than 2 isolate in one subject. Around 45% has more than 2 isolate in the sputum. And this is one of, we don't know whether this data has implication in treatment, because we also did a fluoroconazole sensitivity test in isolate from Aspergillus fumigatus, flavus, and niger, and we found around 18% has not sensitive enough or resistant to fluoroconazole, one of the drugs for Aspergillus. And this is what we found, that serum IgG specific Aspergillus is positive in 22%, and it might be related to AIDS. So based on this early study, we found that 98% subject has fungal isolate detected in this sputum in naive non-small cell lung cancer, and the fungal isolate mostly Candida, but we found Aspergillus niger, flavus, and fumigatus also in higher rate. And we found also that IgG specific Aspergillus was 22% positive in these groups. So based on this, this is next question that we will have to answer. Is there any fungal colonization or infection might be a burden in naive non-small cell lung cancer? And we have to, we don't know whether this has an implication, whether in management or in the prognosis of non-small cell lung cancer. I think, thank you for everyone here, Dr. Anna, and also our undergraduate medical students, and also graduate students here in that work in this project. Thank you very much.
Thank you for the very interesting talk, Dr. Jamal. And then we move to the last but not least session with Dr. Budi Antariksa. Dr. Budi Antariksa with the topic of fungal and bacterial microbiome in chronic pulmonary disease. Dr. Budi Antariksa, PhD, specialist pulmonologist consultant. He is a senior lecturer in Department of Pulmonology and Respiratory Medicine, Faculty of Medicine, Universitas Indonesia, and also in Persahabatan National Respiratory Referral Hospital, Jakarta, Indonesia. Dr. Budi Antariksa, it's your time, please.
Okay, thank you, Dr. Findra. This is my title, Fungal and Bacterial Microbiome in Chronic Pulmonary Disease. Slide. Slide, please. Okay. Most of us know that maybe normal lung is free from bacteria. Next slide. actually the lungs are not sterile. Yeah. Why? Next slide. The lungs are not sterile because the lung is very warm, moist, rich in oxygen, and few inches from oral cavity. That's why some of the bacteria from the oral cavity sometimes go into the lung. Next slide. Is normal lung free from bacteria? It depends on regional growth condition, nutrient availability, oxygen tension, temperature, pH, concentration of inflammatory cell, activation of inflammatory cell, local microbial competition, and host epithelial cell interaction. So if the regional growth condition, if the microbial immigration, usually because of the inhalation of bacteria, microaspiration, and direct mucosal dispersion. And microbial elimination depend on the cough, mucociliary clearance, and innate and adaptive host defense. Next slide. Source of microbes in the lungs, usually from nasopharyngeal aspiration, inhalation, reflux and aspiration, and from bloodstream. Slide. The lung microbiome changes during disease. Next. Respiratory disease in which the lung microbiome has been reported to be altered in patients with a cystic fibrosis, asthma, COPD, IPF, and lung tuberculosis. Next slide. Slide. For example, in cystic fibrosis, CF airways have a unique microbial community structure and reduced diversity compared to the health airways. So from this picture, we see that the CF sputum compared to healthy volunteers is very different. Next slide. And also the patient with asthma. Yeah. It depends on the environment, smoking, animal exposure, antibiotic use, birth mode, and diet, and also from comorbidities like sinus, obesity, and gastroesophageal reflux. Then microbia or microbiota comes from the respiratory and the gut. Next slide. COPD also have a different region of lung with different microbial. Yeah, from this picture, we can see the different side of the lung. They have a different microbiome. Next slide. And then these pictures show that when the COPD have exacerbation, there is many kind of the bacteria play in this exacerbation. Not only in exacerbation, but only when they're stable, it is also different within exacerbation. And then post-therapy also different. And after recovery, the bacteria or microba or microbiome also different. Next slide. And also for IPF, yeah. Disease progression of IPF is associated with altered lung microbiome. Yeah. Next slide. The important thing is how to sample the airways. We can get sputum from sputum. Also, we doing the bronchoalveolar lavage or protected endobronchial brush or bronchoscopy biopsy or sterile tissue sample. But in this pandemic era, it is not easy to get this sample. Next. So the take-home message from this presentation: when healthy, the microbial load in the lung is low, and bowel samples contain a predominance of bacterial taxa also found in the mouth. Bacterial diversity in the lung is very low. In some individuals, there are some differences suggesting that selective pressure exists in the lung for elimination, persistence, colonization, and growth. Next. When disease, the microbial load in the lung increases. Bowel samples now often contain numerous bacterial taxa not found in the mouth, indicating selective pressures in the lung for persistence, colonization, and growth. Next. Active topic of investigation in the field include: first, whether an altered lung microbiome contributes to the disease pathogenesis or is merely a marker of injury and inflammation. Second, whether the lung microbiome can be manipulated therapeutically to change exacerbation frequency of or disease progression. And three, how the diverse and dynamic hemostasis of the lung ecosystem collapse and is dominated by single dominant pathogen in pneumonia. Next slide. So this is our research now. The title is Bringing the Fungal and Bacterial Microbiome of Chronic Pulmonary Aspergillosis for Better Quality of Life in Patients with MDR TB, actually post-MDR TB related lung disease. Next slide. The background is CPA causes lung damage in more than 3 million people worldwide, with the most common underlying disease being pulmonary tuberculosis infection. Indonesia is a country with the second largest number of tuberculosis cases in the world, while the number of CPA cases is estimated to be around 83,000 cases. MDR pulmonary TB often causes structural damage of the pulmonary organ and cause a reduction in the quality of life in the long term. Thus, the impact of the fungal and bacterial microbiome on the quality of life of patients suffering from tuberculosis is very important to study. Next. So the aim of this study, knowing the feasibility and performance of microbiome tests to diagnose CPA in patients has been MDR pulmonary TB in Indonesia. Determine the relationship between the fungal and bacterial microbiome in CPA cases, especially on the quality of life of patients with pulmonary parenchymal structural damage. Slide. This is the sample criteria. The inclusion criteria is more than 18 years. MDR pulmonary TB patient with a history of MDR anti-TB regimen who have been declared cured or have completed the treatment, never had antifungal medication, the result of the sputum three times with the negative, and willing to participate in research and sign an informed consent. Slide. Method. This study is follow-up study from previous research, namely the determination of point of care test in chronic aspergillosis patient in several hospitals in Jakarta and its surroundings. This is 2019. This research was conducted from December 2020 to December 2022 in several hospitals in Jakarta and its surroundings, while laboratory examinations are carried out at the Faculty of Medicine University Indonesia Parasitology Department and Faculty Medicine Universitas Indonesia Integrated Laboratory. Slide. Okay, thank you.
Thank you very much, Dr. Budi, for your presentation. Unfortunately, we don't have any session for question and answer for this session. I would like to thank you again for Dr. Anna, Dr. Jamal, and Dr. Budi, because this is presenting the current and ongoing research project in the Pulmonary Mycosis Center. And for the closing remarks, I want to pass this session to Dr. Anna Rosariani.
Thank you very much, Dr. Findra, that actually lead these sessions. So at the end of these sessions, on behalf of the committee, we would like to thank to all the faculty members, speakers, and moderators. Especially special thanks to Professor David Denning and Dr. Chris Cosmidis, since it is still very early in the UK when beginning these sessions. And we also thanks to all the participants, and we note here that there are almost 500 participants in Zoom and YouTube. And this is the second activities of our seminar, online seminar, supported by the Ristek-Brin, or Ministry of Education and Research, as well as our partners in the University of Manchester and Medical Research Councils. And last but not least, we would like to thanks also to the PT Pfizer Indonesia for supporting our activities to have these educational activities of Pulmonary Mycosis Center and Indonesia Fungal Culture Collection Centers. So we hope that these activities will be beneficial for our knowledge and collaborations. And at the next month, in the last January, we will have the second sessions of this seminar. So we hope that we can continue our work, our study, and our collaboration in this even it is in this difficult condition. Once again, I would like to thanks to all the speakers, Dr. Nadia from the Ministry of the Health, Professor David Denning, and Dr. Chris Cosmidis, Professor Retno Wahyuningsih, Professor Anwar Yusuf, Dr. Budi Antariksa, Dr. Jamal, and also to the moderator, Dr. Erlina Burhan, and Dr. Findra. So by the end of the session, we would like to thanks to all the participants. See you in the next session, and very much. Stay safe and healthy for all of us.
Yeah.
We can end the sessions and have a nice day. Thank you very much for all the participants. Very nice to
Thank you for all of the participants. This is the last session of the event. don't forget to follow the website. Thank you for your participation. Assalamualaikum warahmatullahi wabarakatuh.
Professor Prof. Anwar, thank you very much. Prof. Retno, thank you. Dr. Chris Kosmidis, Professor David Denning, Dr. Uri, thank you. Pak Heri Wibowo.
Terima kasih, Dr. Ana.
Dr. Nadia, terima kasih. Nanti kita lanjutkan untuk diskusi tentang topik jamur ya, Dok ya.
Kalau mau akses obatnya mesti gitu, Dok. Gabung sama TBC atau HIV gitu, Dok. Karena mikosis kan memang nggak ada di program ya. Jadi susah mau ngikutnya sesendiri kali ya, Dok.
Iya, Dokter Nadia nanti belajar dan minta dibantu untuk bisa provide.
Tolong sampein.
Prof, suaranya nggak kedengeran, Prof.
Masa?
Kecil ya.
Mungkin nanti kita diskusi sedikit sambil ngobrol-ngobrol virtual lagi ya, Dokter Nadia ya.
Yap.
Ya, terima kasih banyak. Mohon maaf kalau ada kekurangan tadi dalam koneksi internet ya. Dokter Alfian, terima kasih banyak. Mohon izin, ya mohon izin live juga. Terima kasih.